Great, great. Well, I'd like to call this meeting of the Workers' Compensation Insurance Committee to order. First of all, I'd like to ask any legislators, beginning with myself, to identify themselves if they're on Zoom. So my name is Tom Oliverson from Texas.
Bob Hackett from Ohio.
Ronnie Cromer from South Carolina.
Anyone else? Okay, and then I'll ask the legislators who are present at the meeting in Boston to identify themselves. Oh, I see Assemblyman Cooley. Would you care to identify yourself, sir?
Assemblyman Cooley joins.
Outstanding. Anybody with us there live at the meeting in Boston to identify yourselves? I can't hear them, Will.
Good. I was just checking in with you, see if you'll be able to do one of those if you're able. If you're not able, that's fine.
Okay. Will, do we have a quorum?
Yes, Mr. Chairman, we do have a quorum.
Okay, wonderful. A quorum is present. I'm going to ask for a motion to adopt the committee minutes from December 11th, 2020.
So moved.
And April 16th of 2021. I have a motion. Do I have a second?
Second.
All right. Everyone in favor of adopting the minutes, please say aye.
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 Any opposed? The minutes are adopted. At this time, friends, I'd like to begin with our first discussion point of the meeting. Want to introduce Mr. Jeff Ettinger, who is the Executive Director for Regulatory Business Management at the National Council on Compensation Insurance. And Jeff, the floor is yours if you want to give us your update on the status and trends of workers' compensation insurance marketplace. We can't hear you, brother.
Can you hear me now?
Yes, we can. Please proceed. Thank you, Jeff.
Okay, I'm going to share my screen with you. You should be seeing my slides. Great. Okay, let's see here. We'll get there. Just having a little trouble advancing. Can you still hear me? I'm having a problem sharing my screen or advancing my slides.
Yes,
We can hear you.
Well, I'm unable to advance my slides on my end.
Jeff, if you'd like to stop sharing, I can share your presentation and advance the slides for you.
Yeah, I'm trying to stop sharing, but it appears that nothing is working. So I'm not even sure if I'm visible on camera because I can't see anything on my end. So if you want to share the slides on your end, then I'll just go ahead and we'll I'll talk you through it.
We see Jeff's presentation in the room in Boston.
Yes.
Great, Jeff.
Okay. Well, you can go ahead on to slide 3. I'm going to start off looking at the workers' compensation premium. We there?
Yes.
Okay. All right. So when people ask me, what is the biggest impact of COVID on workers' compensation? This is really it. So, and it's actually an indirect impact. So the recession that was caused by COVID and the shutdowns caused net written premium for workers' compensation to decrease by 10% in calendar year 2020. So the next slide will show you that it does vary a little bit by state, but any shade of blue means that the record premium decreased for that state. So pretty much across the board, every state was affected to some extent. The next slide shows residual market premium, which also shows a slight decrease. But really the important thing to note here is just that the residual market premium has been stable, has been dropping over the last few years, really just showing that the workers' compensation market has been very stable and that insurance carriers are willing to write workers' compensation on a voluntary basis, because the next slide shows that the residual market share has hovered around 7%, and you see there that it's 6.5% for the most recent year. So it's very small, manageable, showing that the market is competitive and companies are able to find coverage in the voluntary market. The next slide just shows the approved changes in the loss costs that have occurred over the last, well, this slide is over the last 20 years, but over the last few years, the filings that NCCI has been making been dominated by decreases. So there was a couple of years there where the decreases over all the states approached 10%, and that's moderated a bit. So in the last year, it's overall minus 5.6%. The next slide will show the reason for that, and that is, this is last year's rate filing, cycle for all the states, and you can see there that it's very dominated by loss cost decreases. The largest one being a 20% decrease in Virginia. Now, the one thing I wanted to mention is the rate filing season is just started. We made our first rate filing last week, and we did release some information on how we have addressed pandemics in the rating process for filings going forward. And the decision that NCCI has made is to treat COVID claims, treat any future pandemics as a catastrophe. And what that means is that any claims from COVID are being excluded from the rate making calculation because they are being addressed through approved catastrophe provisions that we have in the majority of our states. So the majority of our states have both a terrorism catastrophe provision and an additional catastrophe provision for other types of catastrophes, such as domestic terrorism versus foreign terrorism, earthquakes, and catastrophic industrial accidents. So during this rate filing season, we'll be adding pandemics to that list of catastrophes that are addressed by this approved provision in the majority of our states. So you can go on to the next two slides, which slide 10 shows the combined ratio for workers' compensation. And you can see there the latest year, the combined ratio for calendar year 2020 is 87%. And this is the fourth straight year of calendar year combined ratios under 90%, and the seventh consecutive year under 100%. So obviously the line has been in a very strong position for a number of years now. The next slide basically shows that the slight uptick in the latest year's combined ratio is really driven by a slight uptick in the loss ratio. And then the next slide shows investment gains on insurance transactions at 11% for the last 2 years, which is right around the long-term average of about 12%. So the next slide shows that when you combine a calendar year underwriting profit with an investment gain, you see there a pre-tax operating gain of 24%, similar to last year's 25%. So very robust operating gain there for the line. So the next several slides show the information that we have on COVID claims. So in slide 15, here's a basic summary of what our data shows so far for COVID claims. We're looking at about $260 million in incurred losses for COVID claims, and that's made up of about 45,000 claims. So the average for those claims is about $6,000, so fairly small. And the next slide shows that 75% of those claims are lost time claims. Now, normally, for other types of claims, we kind of see the opposite distribution, that 75% of claims other than COVID claims are medical only and 25% are lost time claims. But in the case of COVID, it's the other way around. The next slide shows, the next several slides show how the claims break out by size of loss. So you can see on slide 17 that about 60% of the claims are very small, under $1,500. And if you keep going through the slides, you'll just see the percentages. 1,500 to 5,000, about 27%. 5,000 to 10,000, about 6%. And then what slide 19 shows is that there's a very small percentage of large COVID claims over $100,000, about 1% of total claims, very severe, making up 60% of the losses that we saw before. The next slide, not surprisingly, shows that the overwhelming majority of COVID claims are driven by healthcare workers, first responders, accounting for almost 75% of COVID claims. And as you go through the next slide, it'll just show that rounding out all of the rest of the claims, we do have restaurant workers, building operations, distribution stores, all other, but the majority of claims coming from the healthcare and first responders. So keep going through the slides. Slide 23 shows claim frequency, and what we're looking at here is basically almost every single year we see a decrease in workers' compensation claim frequency, and we see it again in the latest year, the -7%, a little bit larger than the long-term average that we saw, 3 to 4%. And the next slide shows the claim severity. So the average cost per claim, this is the medical claim severity, and just showing that obviously medical claim severity has been going up. Previous year, up 3.7%. The latest year, we had a little bit more difficulty estimating due to COVID claims. We're calling it plus or minus 2%, but has somewhat moderated over time. So that's what the next slide shows. Slide 25 shows that medical claim severity in the latest half of that slide has been more in line with a medical CPI versus the first half of that slide where the blue line was increasing a lot faster than the red line. The next slide shows the average claim cost for indemnity or lost time claims, wage replacement. And the latest increase there is a 3% increase. And when you look at the next slide, it's basically showing that indemnity average claim severity has been changing about the same amount as wage inflation is changing. So both medical and indemnity costs have moderated and are moving more in line with wages and CPI. So the next slide just basically sums up the highlights of what the workers' compensation industry is experiencing right now. Written premium down by 10%, the calendar year combined ratio at 87%. We are looking at an accident year loss ratio of 100%, still breaking even. The reserve position stronger than ever. Claim frequency down by 7%, and indemnity and medical severities, while up, are up in a moderate way. And as I said, we're looking at about $260 million in reported COVID claims for 2020. So the final slide just looks at, okay, what are we keeping an eye on? The system is healthy, the system is strong, but we are looking at, what future COVID claims could happen. Could there be more surges? How long will it take for a premium recovery in the line? We've seen the impact of vaccines, but again, we are seeing surges in many states. Permanent disability, we're just looking at some of those long haul claims and keeping an eye on, some of those claims turn into very high cost claims when there's permanent injury involved. The other thing that we're watching are the presumptions bills that are still being introduced, and some of them, may introduce retroactive features, may expand coverage beyond first responders, beyond healthcare workers, and may start to include wording about infectious diseases that normally would be excluded. And then just looking at how our loss development might be affected by COVID. So really just wondering whether 2020 is an anomaly or will there be lasting effects on the workers' compensation line? So that's all I have, and now next slide is just if anyone has any questions.
Members, are there any questions? Will, do we have any questions in the audience? Assemblyman Cooley?
I wonder if you highlighted the difference between medical expense claims and lost time claims, saying we kind of saw things turn around under COVID. Can you just offer a little more commentary on the characteristics of the lost time claim in distinction to the other type, just for general education?
Sure. So when I talk about, let's say, just your normal everyday workers' compensation claim, so not COVID related, the reason that the majority of those claims are medical only is because, you can have a slip or a fall or, a burn, something that's not necessarily severe. It only requires a little bit of medical attention, but you're back to work right away, or you're back to work within the waiting period. So COVID is kind of the opposite in that you may not be hospitalized. So you may contract COVID or think that you had COVID, and you cannot work. You have to quarantine. You have to stay home. You have to wait it out. So you're paid for your time off while you're doing that, but then you're back to work. And again, this is not everybody, but it's saying that the majority of people who contracted COVID on the job only received those types of benefits and never had to receive any sort of hospitalization or medical benefits.
Gotcha. Okay, Jeff. Thank you. Thank you, Mr. Chair.
Thank you. Jeff, I was struck by what I would consider to be the small dollar amount with respect to the claims that were filed for lost time at work and wages and stuff like that. Are you able to dig into that sort of by sector of the economy where there are certain jobs that were sort of more associated with these claims, or were there any trends that you can tell us? I found that somewhat fascinating. I think if I remember, you said that the average claim was less than or about $1,500 for lost time at the job. And of course, I remember when this pandemic first began, folks were being told they couldn't come back to work for 2 weeks you know, or whatever. So I'm just wondering if you have any more data on that.
Okay, so yeah, so the average claim is about $6,000. So we did run through kind of a lot of small claims. So again, there are a lot of instances, I think, where it could even be that someone, maybe thinks they contracted COVID. So they have to get off work to get tested, whatever. But for a lot of people who contract the disease, it could be mild. So it could be a very short time off of work. So you could just be talking about a few days or even a week, where they have to be off work, and then they're back to work without ever having to receive any medical attention, any hospitalization. And that's pretty consistent even with other states that aren't NCCI states, that the average cost of these claims is relatively small.
The other question I had is, I know when this first began, as I talked to some of our carriers and some of the companies here in Texas, everybody was sort of accepting every claim that came their way because we really didn't have any legal framework for liability protection with regards to exposure, things like that. We didn't have a vaccine. We didn't really know what we were dealing with. I would assume that the trend is that we're starting to see a lot of these claims tail off now in terms of, medical claims severities probably getting a little less expensive. Are we seeing some of the time off work related claims? Is it sort of heading in the right direction from what you can tell?
We really wouldn't have that sort of, up to the minute, data to know whether or not things are tailing off. I mean, the one thing I would mention is these claims that I'm talking about are from 2020. And so just keep in mind, we still have claims that have occurred or occurring in 2021, but we had a large surge at the end of 2020. And then now obviously we're seeing a lot fewer claims, and now we're seeing another surge. So I can't really say what is happening out there. I think there's still going to be work-related claims going forward as long as there are COVID claims happening.
Okay, awesome. Members, any other questions? All right, Jeff, thanks so much for your presentation. We appreciate
Mr. Chairman, I have a question here in Boston.
Yeah, go ahead.
Senator Pitch, and it's kind of from the Arkansas delegation. Those are extremely impressive numbers. But at what level did federal dollars coming into the system perhaps make those numbers better?
Which numbers are we talking about?
Well, whether it would be CARES Act, or if small businesses were able to find funds, et cetera, to not have people file workman's comp, et cetera. I look at that number, and much like Chairman Oliverson, if I said that correctly, that's just too good of a number for us to look at COVID. I mean, we were all running around scared of what that number was going to look like, and here it is, very small. And I guess I'm looking for, much like Chairman Oliverson, I'm looking for why that number is so attractive.
I mean, you're talking about just the number of claims, or the dollars of COVID claims?
The dollar a claim. I'm looking at a $14 billion reserve, and I'm looking at something like, well, whatever it was, I don't have your graph here in front of me, but 240 million maybe in claims. And we're looking at an average claim of 6,000 with 1,500, most of them. And those seem small to me as a small business owner, that if I've got a workman's comp caused by COVID, I've lost an employee for a while to file that, and those are awful small. And I'm wondering if the research shows that small businesses did something else rather than file the workman's comp claim.
Yeah, I mean, I wouldn't know if someone did or did not, decided not to file a workers' comp claim. But again, I will say that the vast majority of COVID claims, are not that severe. So it's a very small percentage that turn out, and obviously, there are deaths involved as well. But that's a relatively small, on a percentage basis of deaths, and relatively small percentage that end up being very long-term, long-haul claims. So I'm not necessarily surprised that the average cost of a COVID claim is small. I think maybe everybody breathed a sigh of relief that the total dollar amount or the total impact on workers' compensation losses has remained relatively small, maybe about on the order of somewhere about 1% of workers' compensation, and part of that too could just be not every COVID claim you hear about was contracted in the line of work, on the job. So as I showed earlier, 75% we're talking about first responders and healthcare workers. So workers' compensation is going to be a small piece of every COVID claim that occurred in the U.S.
All right. Senator, does that answer your question?
It's still an intriguing number, so yes.
I agree. Members, any other questions? Jeff, thank you so much for your presentation. We appreciate you being with us as always. Thanks for keeping us in the know. At this time, members, we're going to move to the second item in our agenda, second panel or second discussion. We're going to be discussing using workers' compensation data and systems to improve safety and health. And our guest speaker is Dr. Steve Wurzelbacher. I hope I said that correctly, Steve. And he is from the Centers for Workers' Compensation Studies with the National Institute of Occupational Safety and Health, also known as NIOSH, as well as the CDC. So we are very excited to hear what you have to say, Steve, and the floor is yours.
All right. Well, thanks very much for the opportunity. Can everybody hear me okay?
Yes.
Okay, great. Well, thanks again. I'm kind of trying to run this off my hotspot of a phone, so hopefully it all goes smoothly here. So again, thanks. And I want to also acknowledge just a lot of folks behind the scenes on our team. One of the folks is here, Alicia Myers, also on the call. And we do work with a lot of folks within CDC and outside partners. So as far as an outline, we're going to give a basic outline of the system potential within workers' comp for improving health and safety, and then give some updates of different types of studies that we have online. And that includes claims, health services, risk and exposure assessment, prevention effectiveness, and outreach. And then we'll end with just some outlining some partnership opportunities. So our basic mission is to maximize the use of comp data and systems to improve workplace safety and health. As I mentioned, really the only way that we can do that is through partnerships, and we try to really build bridges between public health, insurance, employer, and worker communities. When we look at the actual potential of the system, most people think about just claims, and we do focus a lot on claims and what they can tell us about emerging risks and ways to control those. But we also realize that every single claim is a person, and so we can look at how their treatment was conveyed and how they're best getting that treatment to return to work and full recovery. Once more, the insurers actually have quite a bit within the system to do risk assessment. They put people out into the field to do industrial hygiene sampling and safety walkthroughs. And many of the states actually also have risk control programs. So they have people in the fields, and in some states they offer actual programs to fund putting in place like engineering controls. And really the whole infrastructure for workers' comp is a main way that especially small employers are reached for health and safety. So at this point, I'm just going to talk a lot about some of the main focus that we have, which is to look at the claims data. So, you know, as this group knows, workers' comp is really the largest database of work comp or workplace injuries in the U.S. So this includes a variety of reports within each state, you know, from a first report, subsequent, and then detailed information as you go down. But this really entails millions of claims in some single state databases. It includes a variety of information like narratives that describe how the injury occurred, codes for industry and occupation, and then detailed diagnoses and patient demographics. So all this information can be really very informative to understand what caused the injury to occur in the first place and how we can prevent that. So one of the things we did a few years ago was to develop a grant. So the purpose of the grant was to develop collaborations between state workers' comp bureaus, departments of health, and unemployment insurance agencies. So the bottom line goal was to get the states to really be able to use the comp data to trend by industry and cause of injury. So what these states did, this was California, Massachusetts, Ohio, Tennessee, and Michigan. They were all funded. So what most of these states were able to do is take the comp data in their state and link it to the unemployment insurance data. And how they did it is that there's this federal employer identification number that's common in both sets. So these are both state-controlled sets. And so, you know, really it's just within the state that they were able to get these data use agreements. This information wasn't shared in most cases with you know, NIOSH. It's only with Ohio that we have a detailed partnership. But basically what they're able to do is attach then the workers' comp claims and add to it the employer industry and numbers of employees, which appears in the UI data quarterly. And what this allows then is not only just counts of claims, but actually rates. So the number of claims per, say, 100 workers at an employer and industry level. Many of the state reports are publicly available. If you go out to these links right here from Massachusetts, Tennessee, and Michigan, you can see really the depth that they went to within these different reports. NIOSH has also had a long-standing partnership with the state of Ohio. So Ohio is one of 4 exclusive workers' comp fund states, meaning that the state itself acts as the insurance company. So we've had a very rich partnership with Ohio and been able to really put out quite a bit of work recently on claims analyses to look at overall multi-industry, detailed causes of injury, and then drill into specific industries that we knew were higher rated in terms of injury. So ambulance services, temporary services, landscaping, and so forth. And also dig into specific types of diagnoses such as traumatic brain injuries. We have been also working with the workers' comp community on COVID-19. NCCI has been a huge partner in this in terms of what they're able to do and put out on a regular basis. Their dashboard's fantastic, so if you haven't checked it out, you definitely should do that. So many states are also individually putting out information on COVID-19, in addition to NCCI, IIBC, CWCI in California. What we've also done is really host monthly calls. They're open calls. If anybody would like to join, it really is just a sounding board for folks to present data on COVID-19 and share best practices for analyses. We are also sponsoring a number of studies to actually look at more detail on how the actual COVID-19 is related to different worker factors like occupation, age, tenure, gender, and then also employer factors like industry, firm size, and region in the country. These studies are also looking at the impact of, you know, on total injured worker care, not just those folks that have COVID-19 claims, but just overall in the comp system. And a big thing is also looking at the long-term impact. So what are the detailed diagnoses, treatments, disability, costs, and so forth that are occurring within these claims? So what NIOSH has done is we actually are funding 6 states and the Workers' Comp Research Institute to do these analyses. So a number of the states are actually sharing data right now. WCRI has put out reports, as it again has NCCI. So it's basically an ongoing process. So with workers' comp, a lot of times with the size of these databases, we need to develop unique solutions to address the size and volume and types of data being produced. So I'm going to talk a little bit about some machine learning, narrative text mining, and data viz approaches. So machine learning is something that's really been around for a while, but basically what you can do is apply it to narrative text. So for instance, the claims data that says something like slipped on ice, hurt my back, you can actually apply a text mining approach that will code that into a structured outcome. We worked a lot with leaders in the field, including Liberty Mutual and Purdue University, and basically developed some autocoders that can code to 3 levels of causation and also 48 levels. If anybody would like these, we can share them. You know, they're basically free algorithms, and they're either in SAS or Python. In a similar way, NIOSH researchers have also developed automated coding approaches for industry and occupation. So if you have a free text field for either of those, there's a free system that you can go online and it'll actually code it for you. There's a lot of results. You know, we're basically producing dashboards. You know, a lot of folks are doing this, but it basically is a great way to visualize complex data. We list out 3, or actually this is just 3 that we list out on our webpage right now, but you can dig into more details. And internally, we are actually using quite a bit in terms of like Power BI and Tableau to really cut through the data and visualize and understand, again, tapping into the power of that narrative. So that's claims in a nutshell. Health services is the next aspect of what we do. So this is really assessing the impact of healthcare factors on workers' health outcomes, and this can include looking at the person's functional status, whether they could return to work, what's their pain level, and prescription drug use. And the types of healthcare factors are access and quality of care, the type of treatment, what was the care coordination, and then also looking at this type of treatment in with other workplace factors such as the cause of the injury and what was the industry and so forth. We have a number of current studies underway, working with Ohio, BWC, looking at different types of treatment like chiropractic. And then one of our folks is also working on his dissertation with Washington, looking at physical therapy. A big focus is, of course, preventing opioid use disorders among workers. So we have an internal framework for that and hosted a meeting a couple years ago and have sponsored some recent work by WCRI in this area. And we continue to also share research from a number of other organizations such as NCCI and WCRB and so forth. So that's health services. Another aspect of what we do is looking at risk and exposure assessment. As I mentioned, insurers really collect, or some of the largest collectors as a group, of occupational risk and exposure data in many areas. So there's a lot of opportunity to look at this data and whether it can be used to understand risks across industries and whether there's different emerging hazards. So we had 2 studies that looked at whether industrial hygiene data, what's the practice within workers' comp insurance carriers, and what type of standardized forms were being used to collect this data. So the current status is we have been working a lot with the American Industrial Hygiene Association, and they are recommending the creation of a guidance document to kind of guide how data can be standardized. And the proposal has actually just now been accepted, so it's in process. Another aspect of what we do with partners is to work on really identifying what works to prevent injuries. In short, we call it intervention effectiveness. We really look at insurers as ideal partners because insurers provide services and grants and tend to have access to employers, especially state-based ones have access to employers over a long time. Ohio in particular has had a grant where they actually put in place engineering controls. And since 1999, they've had this program. And as of the most recent year, they had paid almost $15 million in matching grants. So it's like a basic 3-to-1 grant. Ohio will pay $3 for every $1 from the employer. But the idea is to actually put in place an engineering control that is needed at the workplace. So we've actually partnered on several studies to look at how this program operates and if it's effective. And not to get into details too much, but it definitely has been shown to be effective. We've gone through and RAND actually did a study because this type of program has been picked up by some other states. It's now offered in about 5 or 6 different states. And some of them are competitive-based programs because Ohio is an exclusive insurer. But we have shown it can work, and definitely it's sparked a number of different studies to look at, in particular, what works, what doesn't work. And then we also are looking at things like the insurer's on-site risk control processes. And then also with Ohio, they actually sponsor an employer wellness program, and Alicia Myers is leading that study, who's on the call. And there are others too. We work with SCIF, which is the state-based California Insurance Fund, and are looking at also in-vehicle monitoring systems. So real quick on outreach. So essentially what we try to do is, again, kind of connect the insurer, public health, employer, and worker communities. We do have a regular webinar series and have a number of different work groups that we form. Right now, essentially, a lot of that work has been focused on COVID-19, but it also, relates to everything else too. As far as recent webinars, we had one back in January on cannabis and workers' comp, which has been a big topic area. We are working on a follow-up paper. Our director, John Howard, is the lead author on that paper, and then includes co-authors from NCCI, WCRI, and IAI-ABC. So that should be hopefully coming out here in the next few months. We also have had ones based on looking at opioid use within the comp system. This was actually presented by folks who looked at really a overall literature search in the area and looking at, summarized a lot of different factors that are effective in controlling that within comp systems. And also one that we did recently that focused on what insurance companies are doing to respond to COVID-19. Again, they're a great intermediary between, basically to reach employers for safety and health reasons. And so they've been doing quite a bit to understand and communicate ways to prevent COVID-19. And in some cases too, a number of these state programs were actually providing funding for engineering controls and PPE such as masks, and then also advancing how they are doing risk control. As far as the toolkit, if anybody would like any kind of information on some of the things we've mentioned, as far as autocoders, crosswalks, denominator methods, and we also offer data viz services. That's something we do for any states and partners that need it. So simply you just have to send in a request and we'll help you any way we can. And I'll just close here by saying that, again, we thrive on partnership. That's how we operate. And so we're always looking for opportunities for collaboration. So if your state is interested, please let us know. We would be more than happy to work with you. And I'll end there and give some time for questions.
Thank you, Steve. We appreciate that very much. I'm curious. So you were talking about some studies ongoing, monitoring, different. I saw one on the use of chiropractic care and physical therapy, and obviously cannabis and things like that. Are these studies? Where would we go as legislators to have access to the results of some of your work? Do you have like a portal where you publish studies or things like that where we can get these things?
We do actually, and so if you go to our webpage there, that website, we basically post everything that we publish on that website. And a lot of times it'll go out to the link for a peer-reviewed journal. But if for some reason you can't access the link to the report, just you would email us and we can give you a copy.
Okay. I've read several of your reports that the agency has put out in the past, and I found them to be very helpful. I've actually used them in developing legislation here in Texas. I'm also curious, do you collaborate with the various entities that run workers' comp programs to sort of develop best practices for treating certain types of injuries and kind of what gets to the speediest recovery? Do you guys do that kind of work as well?
Well, I must say that probably area of our research is the most new. So we're very new to that aspect of it, and so I think that we're we're really just at the beginning of that. NIOSH in general, we focus primarily on what we call primary prevention, so ways to prevent injury from ever occurring. So this is one of the first times that we're really starting to look at what happens after, the injury occurs. But I will say there have been a lot of others that have done, work in this area for quite some time. NCCI and WCRI, Washington State, under Gary Franklin, they've put out quite a bit of work. But so a lot of times, at this point, we would be echoing some of the past work, but we are hoping to make contributions in that area in the future.
Wonderful. Thank you. Members, any questions for Dr. Wurzelbacher? Assemblyman Cooley?
Yeah, I just actually wanted to jump in and make a comment. Earlier this week here in California, we had a bill that came up in our insurance committee. It became controversial, but it was a workers' comp question. And the controversy was there are allegations of misconduct, but not a lot of specific detail data to back it up. And so the bill didn't advance because, okay, there's an argument that there's something broken without actually a narrative and data to support it. And so for the lawmakers on the call, this presentation, Mr. Ettinger's presentation, I think are actually very important for us as lawmakers to take note of, because particularly, for example, in the field of workers' comp, there is a lot of data available. And under your state law, under my state law here in California, carriers are required to collaborate to respond to inquiries from the regulator. So I just want to point out that if we ever as legislators are hearing of an issue affecting the insurance marketplace, workers' comp, that is a moment to think about how could we get insights on this issue out of the marketplace. And yes, the insurance regulators play a very key role, but their role is actually to implement your state law. And so if you're hearing about an issue that interests you, that you'd like to learn more about, that's the time to place a call to your regulator, get their team in to talk with you, discuss the issue, what they have in their systems that might shed light on it, and whether there's some questions either directly to the industry or through some of these intermediary data groups that could help shed light on it. I do think coming to NCOIL is actually learning about, in the insurance space, how to exert the power of our individual offices. And this presentation, I think, is a portal to exercising that power.
Well said, my friend. Any questions from members in the audience? Or legislators in the audience, I should say. Will, do we have any questions?
None here, Mr. Chairman.
Okay. All right. Well, Dr. Wurzelbacher, we appreciate very much your testimony, sharing with us. Appreciate the work that you're doing there at NIOSH, and just encourage you to keep it up and come back frequently and often, because we'd love to hear more.
You bet. Thanks again for the opportunity.
Thank you, sir. Okay, members, we're almost done, but before we adjourn, we're going to readopt some model laws. Per NCOIL bylaws, all model laws must be considered for readoption every 5 years or else they sunset. We have some models today for consideration in our committee, beginning on page 43 in your binders. I would note that there are amendments to the structured settlement model that are currently being developed. So the motion to readopt that model will need to be postponed until the next meeting. And so my motion, we'll go ahead and deal with that one unless there are any questions. We'd like to postpone readoption of that particular model until our next meeting, where we'll have a chance to discuss the amendments that are currently being drafted. So I will entertain a motion to postpone a readoption of the structured settlement model until our next meeting in November.
Mr. Chairman, I'm sorry, just to clarify, the motion would just be it would actually be to temporarily readopt the model just until November, rather than for the full 5 years as the amendments are being worked on.
Okay, I apologize. Let me restate that. I will entertain a motion to temporarily readopt the structured settlement model until our next meeting in November, where we will consider its readoption again.
Mr. Chair, I'll make that motion. Paul Edkey, Minnesota.
Thank you, Mr. Vice Chair. Good to hear your voice. Any seconds?
I'll second that motion. Ken Cooley in California.
Thank you, sir. All those in favor of readopting the structured settlement model until our next meeting in November, please say aye.
Aye.
Any opposed? Okay, the structured settlement model is adopted or is readopted until our next meeting in November. At this time, I'd like to entertain a motion to readopt the Trucking and Messenger Courier Industries Model Act and the model agreement between jurisdictions to govern coordination of claims and coverage.
Mr. Chairman, George Kaiser from North Dakota. I move adoption.
Thank you, sir. Appreciate that. Is there a second?
I'll second that, Mr. Chair. Ken Cooley in California.
Thank you, my good friend. Appreciate that. All those in favor of readopting these two model acts, please say aye.
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 Any opposed? Okay. The Trucking and Messenger Couriers Industry Model Act and the model agreement between jurisdictions to govern coordination of claims and coverage are readopted. Friends, that is all I have on the agenda. Is there any other business needing to be discussed at the Workers' Compensation Committee? Hearing none, I would ask for a motion to adjourn. I'll make a motion to adjourn. Any seconds?
I'll second that, Mr. Chair.
All right. Thank you, sir.
Thank you.
All those in favor of adjourning, please say aye.
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 All righty. The Committee on Workers' Compensation is adjourned. We'll see you in December.
Good morning. Thank you all for joining us. My name is Pam Hunter. Many of you know me. I'm a state assembly woman from New York and chair of the NCOIL Health Insurance and Long-Term Care Issues Committee, and I'm going to be moderating this general session this morning. This is an important panel on obesity, the impact it's having on all of our states, and the developments in the medical treatment for the disease. As you will hear today, the cost of obesity in terms of both human life and taxpayer dollars is crippling our respective states, and we can no longer afford to ignore it. Unfortunately, our private and public health infrastructure is neither prepared to meet the demand nor ready to treat this disease that affects over 42% of Americans and disproportionately impacts people of color and those living in poverty. Recognizing severe obesity as a disease resulting from genetic, biological, environmental factors, not simply a lifestyle or behavioral issue, is the first step. It is directly tied to the increase in other chronic diseases like heart disease, type 2 diabetes, and cancer. Today, we'll hear from experts that will provide an overview of obesity itself, the problems physicians and patients face in treating obesity, and the steps legislators can take to facilitate treatment for obesity while also reducing the state's overall healthcare costs. Joining us today are Angela Fitch, MD, Associate Director, Massachusetts General Hospital Weight Center, Joe Naglowski, President and CEO of the Obesity Action Coalition, and Randy Pate, founder of Randolph Pate Advisors, and former Deputy Administrator and Director of the Center for Consumer Information and Insurance Oversight at the Center for Medicare and Medicaid Services. So I'm not going to take up any more time from our speakers in the Q&A session. So I urge all of you to reach out, read their bios, which is included in your conference program on the app, of course, and then we'll be looking forward to hearing questions from our and my colleagues. So if we could get started with Angela Fitch, please.
Button. Okay, thank you. And there's my slides. Okay, excellent. Such a pleasure to be here. Thank you so much for having me and listening. And I hope after my brief presentation this morning that you will understand that obesity is actually a disease that it's your chemistry and not your character. Because there's a lot of stigma around obesity treatment today, a lot of issues with access to care, particularly because of this stigma, and I think you'll hear a lot about that in the near future. These are just my disclosures. I'm trying to manage both things here. If you look here, this is what was mentioned earlier. This graph is going to rotate here across, and you can see as the years go by, with it starting in 2011 and ending in 2019, the proportion of people with obesity in the red, the dark red states, significantly increases over time, and that is the dark red there is greater than 35% of people in that region struggling with the disease of obesity. The other thing to mention is that adult obesity is also a pediatric disease. So if you look at the graph on the left there, you will see that if you are a patient under the age of 10, for example, the dark blue line at the top, and have severe obesity at that age, you do not outgrow it. What this shows is that people with obesity who are young continue to have obesity into their adult life. On the right-hand side, it mentioned these disparities as well. That was mentioned in the earlier comments. You can see that the people of color, Hispanic and Black in particular, on the top lines, this begins even in childhood. So we see this disparity even in childhood, and it continues on into the adulthood as well. This was a self-reported survey by the American Psychological Association. They run a survey every year called Stress in America. And they ask people about different stresses and different issues. In particular, they talk about weight loss, unintended weight loss, or unintended weight gain. And you can see here that people, proportionally, up to 40% of people reported an average of almost a 40-pound weight gain during the pandemic. So that was unfortunate, obviously, for various reasons. At the top, you'll see there was a JAMA study, the Journal of the American Medical Association study, that actually looked at people with connected scales. So these were people that had scales as part of a study that they were weighing in for a different reason, just happened to be during the pandemic. And it showed that there was on average a 1.5-pound weight gain per month during the pandemic. So if you think about that over the course of a year, that's getting close to 15 pounds of actual reported weight gain during the pandemic. Our ultimate challenge is here, and I suspect just by nature of statistics that some of you in the audience may feel the same way, and that's not to blame anyone or cast doubt on anyone, but the thing is that most of our society believes that even though obesity is a disease, so if you look at the top part, 65% of people with obesity feel that it's a disease, as well as 80% of healthcare professionals. So there's still 20% of healthcare professionals that don't believe in obesity as a disease. So if you're one of those people out here today, you're not sort of alone, right? And 65% of people with obesity believe it's a disease. But down in the bottom, you will note in the red that in people with obesity, 82% of those people feel that it's their own responsibility to fix it, despite the fact they feel that it's a disease. So we don't have any other diseases like that. If you have cancer, you don't think you're going to cure your cancer by yourself, typically. You go to the doctor and you get help for that. You don't believe that you're going to make yourself better, right? And so this is our big challenge that we have. Obesity is a chronic, treatable, multifactorial disease. This is not people's fault, right? This is a disease, and it's got a lot of factors that we'll talk about in a second. But it's really a disease of excess body fat. Today, we define it by body mass index, which is just your height and weight, and there's been some critical discussions around that of late. But that's the best indication we have today that's the easiest to measure. But it's really about excess adiposity, because excess body fat is inflammatory, and excess body fat has disease implications. This is a systems map. There are people that do systems mapping in the world. They map the overarching themes of different diseases. You can have a systems map for cancer, for example. But this is how complicated obesity is. It's not about your character. It's about your chemistry. It's about all these other things that play a role. It's the environment. It's a lot of factors that play a role. The other issue is this, in particular. As people lose weight, on the left-hand side, decrease their intake, increase their physical activity. Unfortunately, the human body responds on the right-hand side by pulling back and slows down one's metabolism, increases your hunger hormones, and decreases your satiety hormones or your fullness hormones to cause the weight to come back on. Your body doesn't know that the excess weight you're carrying is not supposed to be there. It tries to maintain its weight at all costs. This is the human body. I tell patients all the time in the office, you don't get in your car and expect it to fly because it wasn't engineered to fly. The human body was not engineered by whoever you believe created it to lose weight. It was engineered to keep weight on at all costs. So losing weight is metabolically abnormal, and we have to help people in order to do that. These are some of the factors that affect our set point. So you can see if you look at the thermostat on the bottom, that's our weight set point, and our body wants to keep it there. That is defined by genetics predominantly. Up to 70% of weight struggles are genetically caused. They're genetically inclined. But the factors around this circle all play a role, right? These are the things that we can obviously work on and change to a certain degree. Stress, inadequate sleep, inadequate physical activity. These are the things we all work on all the time. But again, it doesn't mean that that's the only cause of the disease or the only treatment for the disease. Here you will note in the red highlighted box that the risk of death from COVID-19 in people with a BMI greater than 40 was up to 17-fold an increased risk of death. You had 17 times the risk of death of dying from COVID-19 if you had a BMI greater than 40 during the pandemic. If we could have offered those people effective treatment and lowered their BMI down to 32, that would lower them almost to the same risk, or almost at 1 or 1.5 times the increased risk. We have treatments that can do that today in the 6-month time frame that could have saved millions of people had they had access to these treatments. But because there's limited access to these treatments, they were not able to get that treatment or weren't aware that it was this important to get that treatment. And likely millions of people actually probably died unnecessarily due to their obesity. What works for obesity treatment as a whole is simplified here, and I don't mean to simplify that systems map, but I like to think simply as well, is that we need structure as humans, we need accountability, we need a metabolic alteration that promotes this fat loss. Like we talked about, it's not normal to lose fat, so we need something that actually helps you to have an advantage here. And we need an environmental stimulus control, because we know that our current environment is obesogenic. Our current environment by 2030, 50% of the population are expected to have obesity. Another 25% of people are overweight. That means 75% of our population has excess adiposity or excess fat storage. That means that our environment is producing it 3/4 of the time. This is not, again, people's faults. If you free live in the environment, you will have excess adiposity. So you have to choose to not free live in the environment or choose to make different choices in the naturally occurring environment in order to be successful in this situation. These are our treatment options. It starts with lifestyle modification, as we talked about, but it doesn't have to start there necessarily, meaning everybody makes these lifestyle changes. But if you notice on the right-hand side, lifestyle modifications are shown to cause a 2 to 5% weight loss on average. So if a person needs to lose more than 2 to 5%, why would we limit their treatment to only a lifestyle-based approach? If they need to lose 10 to 20 to 30%, we would then employ, if you look in the middle, medication therapy for their obesity. And that's why if you have a BMI greater than 30 or a BMI greater than 27 with some sort of comorbidity like sleep apnea, hypertension, et cetera, it is indication for medical intervention. It's very similar if you walked into my office with a blood pressure of 180 over 110, which is extremely high. Normal blood pressure is 120 over 70. I typically wouldn't think that we would be able to treat that level of hypertension with just diet and exercise, less salt and more activity, right? I would give people a medication to prevent them from having a stroke or heart attack in the next few weeks. This is very similar. We have these interventions now today that can affect obesity intervention greater than the lifestyle modification that we have available that we've had for long periods of time. Of the people with obesity, if you look here on the left-hand side, these are the people that are indicated for treatment of their obesity with a pharmacotherapy type of intervention. And that's upwards of 40% of the US population. However, only that small yellow bit of people, less than 1% of people have access to these medications, so only the 1% of people are treated. Whereas you look at type 2 diabetes, on the right-hand side, most of those people are treated with some sort of medical intervention because they have access to that care. And we know that they do better that way. This is a study showing medication treatment for obesity. And this is a unique study because they had these patients lose weight first. So they randomly assigned them at that first dotted line there. Those people lost 5% already. So they were the biggest losers, so to speak, in the lifestyle intervention. They lost this 5% of their weight. And then they were randomly assigned to medication or no medication. This was a study looking at the fact that maybe we could help people keep the weight off, because that's a secondary challenge as well. And you can see here that the people that were on medication, which are in the pink line on the bottom, those people lost another 5 to 10% and got even better treatment for their obesity. And the people in the black, which were in the placebo arm, lost a little bit more, but then again maintained that weight loss. You can also, this also highlights at the end of the study, the second dotted line is where they put the people that were on drug back on placebo. And you up. Because we do know, as with any disease, like with hypertension, if you treat your blood pressure becomes normal, you then actually stay on the medication, because if we stop it, your blood pressure usually goes back up. There we go. And it's important that we talk not about success and failure, but responders and non-responders. So we also know with any intervention, any treatment, there are responders to that intervention and there are non-responders. The graph you see overlaying here is a plot of people in a treatment, right? So the people on the left-hand side actually gained weight. The people on the right-hand side lost weight. So each of those bars is a human, right? That's how they did in the study. You can see that the one person on the far right was like doing a really good job, right? He was, or he or she was like really losing weight, right? This is what we see in science, whether this is cancer treatment, hypertension, et cetera. We know that some people are responders and others are non-responders, typically due to genetics and other factors. Sorry, I'm trying to advance it. Okay. Okay. So I also want to highlight pediatric obesity. Pediatric obesity, up to 17% of children in our country have obesity today. And thankfully, we do have effective treatments for them as of today. Liraglutide was just released last fall, which is a very effective drug treatment. I just saw a 16-year-old who plays softball 5 times a week on a very competitive team, who has obesity, whose parents have obesity, who was eating, a healthy diet, and she could not lose weight, and she was very, very struggling, and she came in to see me having taken this medication and has lost 16 pounds already, and she is just ecstatic that she is finally successful with her weight treatment. And so it's important to recognize that we do have effective treatments, but unfortunately, for example, our patients who need it most, which are patients on our Medicaid plan or our Mass Health here in Massachusetts, do not have access to this medication because a lot of treatments, as you'll hear, are not covered for obesity because they're excluded from plans. So individually, we're one drop, but together we're an ocean, and that's what I hope that we can change here in our discussions today and move forward in our country. And I just give you some of these high-level things that we could do, in my view, as a person who treats obesity every day, is include anti-obesity medications, surgery, lifestyle support into standard benefits for insurance, because right now it is something that employers have to add on as a treatment. It's the only disease that we exclude from plans and then have to add it on. As we know, there's the Treat and Reduce Obesity Act that is before Congress right now that would add these types of treatments to the Medicare, for Medicare beneficiaries as well. And covering the diagnosis of obesity. I'm the vice president of the providers, over 5,000 of us across the country now. And I'm shocked to learn that many of my colleagues in other states and other places, if they bill obesity as the primary diagnosis on that visit for a patient, it's not covered by the patient's insurance. And I think that's just, atrocious, right? That they can't, help that patient with that disease. And then the other big thing is the prior authorization restrictions around these medications. So we have very good medications today that allow you to lose 20% of your weight. So again, if we look at the science and the data, if you're doing lifestyle intervention, only about 10% of people can lose 20% of their weight. That's the science. Only about 10% of people can do that. So if you're 250 pounds and you want to lose 50 pounds, which is not unreasonable, you only have a 10% chance of doing that with lifestyle intervention. Yet if we add medication, we take that up to 40%. Now you have a 40% chance of doing that. Yet as a doctor, I have to tell you to do this for 6 months first, to try this to be one of the 10% for 6 months before you can get access to a medication, because that's what the prior authorization restriction says I have to do. So I have to provide you a substandard care, a substandard treatment for 6 months, because you can't get access to this medication until you have quote unquote failed that lifestyle intervention. And that's what I think is not fair to our people in the country, and would like to change. So with that, I will turn it over. This is just part of our team at the Weight Center. I will turn it over to Joe, and I will I have to go to something else for real quick, but I will be back for Q&A. So please save your questions. I will be back. Thank you.
Thanks, Dr. Fitch. And as my slides come up, I will shift gears a little bit. So I'm Joe Naglowski. I'm from the Obesity Action Coalition. We're actually a charity that is focused on addressing the obesity epidemic. And curiously, our group is actually made up of people who struggle with our weight, right? We actually are people who have 75,000 people across the US who have raised our hands like I have and said, I have obesity. Not very many people raise their hand to say they have obesity because this is a challenging issue and a stigmatizing one. But I think it's important, right, that we recognize that obesity is complicated. And again, as Dr. Fitch shared with us, it's not a condition of personal fault. It is a very complicated condition. And so I'm going to shift and talk about access to care and really want to help frame who seeks obesity care. Because I think one of the big fears, you saw some of those numbers that Dr. Fitch presented, that 40% of people have obesity. Does that mean 40% of people are going to seek medical care? And I tell you right now, the answer is no. We'll talk more about that. I'll talk to you about a little bit more about the current access to obesity treatments, what we know about it, what we don't know. And then I'll talk about what barriers we put in place. We have this tendency to, and Dr. Fitch alluded to this, make people earn treatment for obesity instead of, hey, if you wake up this morning and says, today is the day I want to do something and take advantage of that momentum, we put barriers in front of people. And I'm convinced that's actually one of our challenges. And then finally, I'll look at some potential initiatives that you can consider back home. So who seeks obesity care? So individuals actually seeking comprehensive obesity medical care is actually relatively low. Only about 10% of people with obesity actually go to a medical provider. I'll show you some statistics about who they really go to and what they really do in just a few minutes. But many people don't seek care because of the stigma around obesity. So if you are like me and you struggle with this issue, you've likely been told your entire life that this is all your own fault, right? That this is some failure of your own willpower. And we've been told this is something we have to deal with ourselves, right? We don't like to talk about it and we don't like to ask for help for it. And I think this lack of understanding is one of our barriers as well. We have to make it okay for people to ask for this help. The other thing is our healthcare system has made this even more complicated in that, unfortunately, we don't all have doctors that are as compassionate as Dr. Fitch is. And again, if you struggle, again, like I do, you've likely had a negative experience with your healthcare provider about your weight, right? You've got a finger wag, right? You said, hey, don't come back until you lose 20 pounds or something along those lines. And the reality is our system isn't doing a great job in encouraging people. You telling me I'm fat? No duh. I look in the mirror every morning. I understand that I struggle with my weight. You don't need to tell me that I'm fat. You need to tell me how to help myself moving forward with this, right? And I think that's one of the challenges with our system. The other issue, and you've all seen this and probably outside the scope of this, but our other challenge is there's a lot of short-term snake oil, non-evidence-based treatments, right? Obesity care is not about getting thin in 6 weeks or 12 weeks. I have obesity, okay? My BMI is not above 30, right? My BMI is below 30. It used to be above 30. I still say I have obesity because once you struggle, you always struggle. This is not a short-term problem. People will actually struggle with their weight, likely their entire lives. There might be a rare exception in this room who's someone who once struggled and never struggles again. But I would think most people who have struggled before likely struggle moving forward. And again, I really just want to emphasize that this comprehensive care is modest at best, right? People don't utilize it. So honestly, I have a lot of insurers who come to me and say, or employers say, I added a benefit, we made it easily accessible, nobody used it, right? So we have a different message we have to deliver here. It's not just about access, it is about some of the messaging we need to deliver around these issues. So let's look at some of the data around, I talked about what people do to be able to help themselves with obesity. And you see this here, right? So only 10% of people go to a healthcare professional to seek help for their obesity. 50% try to do it themselves, right? Which almost all of us have tried. If you've ever struggled, you've tried to do it yourself. 30% have given up, okay? And that's a reality that we face, right? Many of us have tried this for decades. My experience is 30 years long now with obesity. Notice that only 7 people say I don't have obesity, right? So there actually isn't a denial problem. Many people think there's a denial problem in this country. There's not a denial problem, right? Most people get that they have obesity. But I just will emphasize that that number that seek medical care is low. It's probably too low in my opinion, and that's because of the way our system's set up. And notice that when I talk about medical care, it's not only seeing someone as skilled as Dr. Fitch was, it's seeing a dietitian or a psychologist or others. And actually that's where you see more care delivered for obesity as well. The other thing I want to talk about is we spend a lot of time talking about how people with obesity consume a great deal of healthcare resources in the long term. But I would argue that that's not necessarily true in the short term. You know, you can actually see from this side here that on average, people with obesity spend less time in their doctor's appointment. Now you're still paying, if you're a payer for this, you're still paying the same amount to that doctor, but the doctors are actually not talking about obesity, because what happens in those visits, this happened in almost all of my visits for a decade, is I didn't want to talk about my weight. I hoped my doctor wouldn't raise my weight. And my doctor probably said, well, if he really wanted to talk about my weight, he would raise it. And so therefore we never had the conversation. And my annual visits were super short, right? He just wrote me my blood pressure medicine and my knee osteoarthritis medicine, and I was out. But guess what? If we had talked about obesity and after we did, I don't have to take those medications anymore, right? And so it's a barrier, but it does. So people with obesity are not spending appointments in marriage time. We also have the tendency not to do our preventative work, right? So we have a tendency not to go to these screenings. These all have long-term consequences, right? You not doing your preventative care is what harms you in the end, and ultimately adds huge costs for obesity in the long run with that. I want to spend a moment talking about obesity in communities of color. So one of the harsh realities that we see is that obesity is more prevalent, especially in women, in both in the Black and in the Latinx community. We have to recognize that there are complicated issues around this that are challenging to address. I also will admit that what we saw from Dr. Fitch earlier, some of that information about BMI may not apply in all of these communities. In fact, one of Dr. Fitch's colleagues, Fatima Cody Stanford here at Harvard, did a study where she actually looked at people's ethnicity or race and compared to what BMI would be most appropriate for them. And for example, in her studies, obesity for Black women is actually probably closer to a BMI of 32 or 33. But if you're of Asian descent, it might be closer to 25 or 26, right? So sometimes we get obsessed with BMI, and I would just urge us to be careful with that. The data does suggest that 4 out of 5 women who are Black or Latina have overweight or obesity, and that's a challenge. We have to address that. We have to work issues specifically around those colors, around people in those communities of colors. We also saw, as Dr. Fitch highlighted, around COVID, excess COVID deaths around obesity. Part of this may be contributed to these racial disparities as well. One fact that often shocks people that's worth acknowledging is that 10% of women in this country have a BMI over 40. So 10% of women in this country are 100 pounds or more overweight. So we've failed when it comes to addressing these issues. Everything we have done to date to try to control obesity, to prevent obesity, has been unsuccessful. And part of that is that we don't make it easy to get care, right? So if you look at what care looks like, it's really hard to find your obesity care. It's all over the place in your insurance product or your wellness program if you're part of a large employer. But theoretically, everyone should have coverage for counseling about their body weight, about obesity. This is required under the Affordable Care Act, Obamacare, and basically it's a preventative service as a B rating. So it's intensive counseling or intensive or screening and intensive counseling for obesity care. The challenge is how this has been implemented in many states is they forgot the word intensive, because one visit a year is not intensive. Actually, the definition under the Preventative Services Task Force, intensive is 12 or more visits in a year. So the reality is that's a challenge. The next line you see here is you see a typical exclusion. This was mentioned by Dr. Fitch as well. You typically see these outright exclusions of obesity and what they use the word morbid obesity. I don't use that word. Severe obesity is the preferred term. But you see these outright exclusions of this care. For a long time in Florida, before I went on my wife's self-insured plan, I lived with this, right? The plan actually said we cover nothing to do with obesity or severe obesity. That was provided by the Obesity Action Coalition. That was the health insurance provided by my organization. For no amount of money could I buy a plan for my employees that didn't have this language in it. That's a challenge, right? If we're really thinking about these issues. We'll look at this more, but if you can look at what services are covered. So bariatric surgery is by far the best covered service. Medicare, federal employee health plans, almost all Medicaid programs. That says 44 of 50 states. Since I wrote these slides, another state, Louisiana, passed some legislation and the governor signed it, adding state employee coverage for bariatric surgery. So now 45 states cover, for state employees cover it. Almost half of essential benefit plans actually say bariatric surgery is essential. And I'm going to show you a map about that in a little bit that's very interesting. And about 65% of employers cover bariatric surgery. But as I mentioned earlier, all these coverages, whether it's going to WW or TOPS Club, which is basically the nonprofit version of WW, or going to the YMCA through the Diabetes Prevention Program, that might live in your wellness program. And then the preventative services might live in a different part of your insurance. And then going to your doctor may live in the third part. Getting pharmacotherapy lives in the pharmacy benefit. Getting surgery lives in another place. And one of our challenges is that these are all separate lines and there's no connectivity between them. We're not moving people through these as we need to. And I think that's why we see sometimes people languish for a decade or more and actually reach these much higher weights. So the other reality of coverage, and I mentioned this earlier, is that we make people jump through hoops to get this. So if you woke up this morning and said, today's the day, I heard you talk, Joe, I'm going to go seek obesity care, it's likely you're going to have to earn the right to get it. That even if you have coverage, there's such a fear that it's going to be overutilized that we put these barriers in place. And honestly, I would just argue with you, these aren't the right barriers. Yes, we probably, to get started, have to create some kind of limitation to care, but let's do that by putting people into comprehensive programs that cover this. Our friends in surgery, the reason why they have such good coverage in bariatric surgery is they did that, right? They created centers of excellence. And so there are these programs that are comprehensive programs, and that's why they have such good coverage. The reality is we probably need to do that for general obesity care as well. The other thing I will say, and I've mentioned this again, is that obesity isn't a one and done thing. So this is the barrier that bothers me the most. If you suddenly said, you can only have one type of treatment, or you can only have one surgery, or you can only have one medication, we don't do that with any other condition. Why are we doing that with obesity? So it's important that we recognize that. Another area that is troubling in some ways, and especially when we see the disparities with obesity, is we have the tendency to charge people higher copays for obesity care. And again, why are we discouraging care instead of encouraging it, right? I think this is, especially when utilization is so very low. So I promised to show you this earlier. This is the essential benefit map, right? And so if your state is other than red, you likely cover some obesity care as an essential benefit. You might remember back to Dr. Fitch's opening remarks and showing those BMI slides. And guess where the highest BMI rates are? In the states that don't offer coverage. It's not a direct correlation, right? But to me, it is one of the explanations. There are lots of others with social determinants of health, other things that take place in some of these other states. But it is one of the factors that is quite noticeable, that there are many states that have very high obesity rates that unfortunately are not providing access to obesity services. Just flipping through a few more maps. This is obesity counseling under Medicaid and state employee plans. So you can see actually state employees have almost universal coverage of obesity counseling. But notice that, and it may be too small for you to read, but some states only offer one visit a year. And again, that's not obesity counseling. A single visit for an issue as complicated as this is not going to suffice. You see Medicaid, we just have a few exceptions without Medicaid coverage. This is now moving on to the obesity medications. So our yellow states are non-covered. The outright gray, which I think we only have one, is we couldn't find the information. And then the blue and then the hashed blue marks are actually covered. Some may be covered with limitations, but you see that we've started to pick up some for state employees and for Medicaid around obesity pharmacotherapy. Now, when we did this analysis with a group called the Stop Obesity Alliance, they said basically if you cover any medication, we do it. Doesn't mean people have the comprehensive list of medications. I know Dr. Fitch didn't go into detail about them, but there are multiple medications, but at least one was covered for this. That is actually slight progress. We've seen some progress in this. And in fact, I think in Minnesota just this week in a bill, or just when the governor signed the budget, they added medication coverage in Medicaid in Minnesota. We mentioned Medicare, just so you know. So Medicare lets you get counseled by your primary care physician for your weight, and it covers bariatric surgery. It does not cover a specialist treating you for obesity. It does not cover a dietitian treating you for obesity, and it doesn't cover medications. This is a challenge. We actually have the legislation that Dr. Fitch mentioned, the Treat and Reduce Obesity Act, very bipartisan legislation that's before Congress right now trying to fix this. Let's let more providers counsel. Let's make medications available. Let's make the coverage in Medicare comprehensive. Oops, I will go back one here. Employer coverage. We have good data on bariatric surgery. I'll show you that in a minute. Some large employers may be exempt from some aspects of the counseling benefit under the Affordable Care Act, although those are diminishing. And there are, as I mentioned earlier, many of these programs live within employee wellness programs, not necessarily their traditional health benefit. Our challenge is that when we survey people with obesity about their wellness plans, only 17% of them find them useful. Wellness plans, these kind of, you do a health screening and they offer you certain things, are really for well people. They're not for sick people, right? And this becomes a challenge with that. And with that being said, I think there are well-designed ones, and there are ones that can be better designed that really are to help people find this care. But and I will just emphasize here that I do not believe all obesity care has to be delivered in a doctor's office. It can be delivered in the community. Our Ys do a great job with the diabetes prevention program. Other groups like that, we can make this work, and we'll have to, right, with the sheer number of people that need to be treated. And because we talked about medications earlier, I will acknowledge that we do see medication coverage growing, as we saw in the state employee and Medicaid programs as well. This is our bariatric surgery data. This is the best data we have on coverage. You can look at employer size and then what's covered here. All the different colored bars are years, and then you see employer size at the bottom. And as you can just see, there's an upward trend across the board, right? Bariatric surgery has won over both the medical community and the health insurance community. It is pretty widely covered. Not perfect. I still have people call us to this day without coverage, but we're getting better about it. So I'll end here with just a couple things for you to consider when you go back home. Maybe because finding obesity care is so challenging, whether it's for the plans you oversee, whether that's your own employees, state employees, whether it's Medicaid, whether it's the ACA plans, why not challenge the departments that do that work to actually put forward a comprehensive list of what we do cover and what we don't cover, instead of making people try to find it themselves. It's really a simple way to do that. I then would encourage you to say, once you know it's covered, let's take a look at where the gaps are. And if you need a reference, there's a reference to those gaps, a great document to say, if we were going to put forward an ideal benefit, what would it look like? What would be covered, right? And that's the link that you see in those slides, and we'll make sure that's distributed to you. The other thing I would really challenge you is to ask your folks who are managing these things, how many people are utilizing these services? Are we worried about utilization when there is no utilization problem? In fact, probably the problem is utilization is too low. We aren't going to improve people's health or ultimately save the state money unless we care for these folks and lower their costs by improving their health. If no one's using these services, yes, we save a little money on day one, but it costs us lots of money down the road. And just remember, as I wrap here and turn it over to Randy, this issue of stigma is the biggest challenge we have. We are not going to shame and blame people into losing weight. Obesity care fails people. People don't fail obesity care. I've heard this before. I won't pick on the person who mentioned this earlier. They talked about someone out eating a lap band, which was a bariatric surgery treatment. And actually, I shifted the conversation. I said, no, actually, his treatment failed him, right? Because the reality is that there wasn't the system around that person to make sure that they didn't engage in that behavior. We can't think about this condition just being about personal fault. We can't continue to blame ourselves. Nobody blames themselves for failing chemotherapy, right? You just say, hey, that chemotherapy didn't work. Let's move on to the next treatment. But with obesity, we have this tendency to say, hey, that didn't work. That's your fault. No, it's not my fault that treatment didn't work. It wasn't the right treatment for me. My healthcare provider wasn't skilled enough, or it just wasn't going to work and we needed to move on to the next one. That's the best solution to move forward. We've got to stop thinking about obesity as just a one and done and about blame and shame. So Randy, I'll turn it over to you to go through some of the logistics of how we can really influence these health systems.
Thank you, Joe. Appreciate that. And let's get the slides here. Okay. Thank you, everybody, for being here today. This is such an important topic, and I know it's on the forefront of a lot of people's minds, especially as policymakers, when you're looking at the impact of obesity. My fellow panelists have really done a great job of laying out the problem and talking about the obesity rates in the country, the toll of this disease on our health, our mortality, our healthcare system. And then Joe did a good job of talking about the current state of play in coverage for treatments for obesity at the state level. But as the former director of CIO within CMS, I oversaw the Affordable Care Act provisions and implementing regulations for both the individual and small group health insurance markets. And so my remarks today are really going to be more on the tools that U.S. state legislators can leverage, and including some of the aspects of the Affordable Care Act in addressing obesity. So it's really more of a toolkit that I want to put out in front of you today. And I will say, as a former regulator, I'm really keenly aware of the trade-offs that are involved in balancing cost and coverage and encouraging competition in health insurance markets. And so my remarks will really be geared towards that, and I'll try to highlight some of those trade-offs in my remarks. But before I get into sort of specific options, I wanted to provide a quick overview of what I feel are the most relevant ACA market rules that are part of the toolbox here. So first of all, in addition to the ACA rules on guarantee issue that we're all familiar with, renewability, modified community rating, and so on, the statute requires insurers participating in the individual and small group markets to rate all their members in a single risk pool. And this means that insurers have to use the total combined claims experience of all their non-grandfathered individual or small group plans in a state to establish an index rate for that market. And then the index rate must be used to set the rates for all the insurers' products in that market. And while the single risk pool concept is essential in a guaranteed issue environment, which is required by the ACA, and it can work fairly well if there are enough healthy lives entering the market, as many of you are probably aware and have seen in your states, the ACA individual market single risk pool has really historically been sicker and has been characterized by more costly conditions than either large group or small group markets. This has contributed to higher premiums and has created a significant challenge for the stability and affordability of many markets around the country, especially for those with higher incomes who don't qualify for the ACA's advanced premium tax credits. So instability of the risk pool is a big reason why the ACA has failed to meet the Congressional Budget Office's initial enrollment projections for the individual market. The statute also requires non-grandfathered plans offered in the individual and small group markets to cover essential health benefits, and we've talked about that a little bit. And that includes items and services in 10 benefit categories, including emergency services, hospitalization, prescription drugs, and preventive and wellness services. Federal regulations define EHB based on state-specific EHB benchmark plans. So for plan years 2020 and later, CMS regulations provide states with some significant flexibility to update their EHB benchmark plans even every year if they so choose. This flexibility includes selecting an EHB benchmark plan used by another state. So if you're in one state, you can adopt a benchmark from another state. You can swap one or more categories of EHB under the benchmark plan with the same category from another state's benchmark plan, or you can develop an entirely new set of benefits that would become the state's EHB benchmark plan. While delving into the complexity of this can be really time-consuming for states, so far CMS has approved changes for 6 states around the country, and those are Illinois, South Dakota, Michigan, New Mexico, and Oregon. While states have the opportunity to enhance or add benefits through this flexibility, any enhancements must be generally offset by restrictions in other areas in order to meet the regulation's generosity test. States also have benefit mandates that may be in addition to the benchmarks or that may fall outside the 10 EHB categories. The ACA requires states to defray the actuarial cost of any new state mandated benefits added after 2011 and make payments to either the issuers or the beneficiaries to negate increased premiums. While no state has fallen into this category as of yet, in the 2021 Notice of Benefit and Payment Parameters, CMS signaled that it intends to take an increased oversight role in determining whether a new state benefit mandate requires defrayal. The ACA also includes 3 programs, 2 temporary, 1 permanent, that are intended to mitigate insurer risk and reduce pricing uncertainty in the market. The Permanent Risk Adjustment Program seeks to reduce incentives for health insurance companies to avoid enrolling people with pre-existing conditions by providing payments to plans enrolling those members with higher healthcare costs. Next, as we've talked a little bit about, the ACA also requires that health plans in the offering non-grandfathered group or individual health insurance coverage provide coverage of specified preventive services without cost sharing. And that includes evidence-based items that have an effect of rating of A or B in the current recommendations of the United States Preventive Services Task Force. And Joe mentioned that there are a couple of items in there that address obesity and screening, primarily around screening for obesity for adults and children. So in addition to these market rules, the ACA also provides states with ability to waive certain provisions under Section 1332 state innovation waivers, as well as authority for state wellness demonstration projects. And I'll get into that in more detail in just a minute. So now that we've sort of talked about these major levers for addressing obesity coverage under federal law, and there's a state component in each of those, I believe, I'll briefly touch on how insurers play a role in covering new interventions to address obesity. So we're all familiar with obesity's contribution to chronic conditions, early death, but the disease also has a significant impact on the risk pool and the premiums we all pay for health insurance. Many studies have attempted to estimate the cost of obesity to our economy and healthcare system over the years. And while these studies vary widely in their methodologies, they all point to a significant and growing cost of obesity in the US. The CDC's most recent estimate is that obesity costs the US healthcare system $147 billion per year. And while the cost of the disease increases as you get older, and say when you reach Medicare age, obesity remains very costly for the under 65 population served by private insurance. In fact, while I was at CMS, we were looking at some state data on for the risk adjustment program, and we were looking at the highest cost hierarchical condition categories. You know, what are the highest cost diseases in each state? And in many states, all 3 of the most costly conditions, the top 3, shared obesity as a risk factor, and that's in the under 65 population. So the CDC numbers are useful in just putting together a rough illustration about the decision process that insurers and their medical directors go through in deciding whether how to cover a new intervention. While medical directors and their teams are focused on safety, efficacy, and effectiveness, when they're looking at new drugs and therapies, as well as the potential to improve quality of life, cost is also a factor that has to be considered. So if you were to take, just as to get a rough idea, if you were to take the CDC's estimate of around $400 annual cost per American of obesity, and you consider that as a percentage of the average individual market benchmark premium for a 40-year-old, around $5,000, it's roughly 7 to 8% of the premium for that plan, which is a big number. So if we want to continue this example, we could assume that there's a new drug or therapy that is coming onto the market that, if it's properly adhered to, provides a complete cure for obesity. Let's say we had that. With that information in hand, insurers would basically look at how much the new intervention costs, and if the cost of covering that intervention is less than the lifetime cost of treating the disease, then the intervention would be covered. But unfortunately, actuaries are often forced to price therapies with very little or no data on their effectiveness or their impact on lowering costs. This can not only slow the process of adopting new and innovative therapies, but it can also stymie innovation in developing new treatments. So I think better data on quality and outcomes are really needed to address this. The challenge of capturing adequate data on cost and quality really make it more difficult to demonstrate cost savings of both existing and new interventions. One idea that states and the federal government could consider is to require additional information to be captured on claims, for example, such as data on outcomes rather than just diagnosis and discharge status. Another key issue is that even if insurers have good data on cost savings, they often do not reap these savings because members frequently shift plans from year to year. It's sort of a wrong pocket problem that can, again, slow down coverage and adoption of interventions that show the potential for longer term cost savings. The risk adjustment program, if it's properly used, can help address this issue by incentivizing issuers to price to the overall risk of the market rather than just the risk of their members. But the risk adjustment program as it operates today can be unpredictable, especially for newer or smaller issuers in the market. And it also requires reestablishing diagnoses every time a member switches plans. So if I switch a plan from one year to the next, I have to go through the process of being re-diagnosed and having my conditions identified for the risk adjustment program. States could look at innovative ways to improve in this area, such as by allowing individual risk scores to really flow from issuer to issuer as a member switches coverage. Reinsurance programs can also help plan actuaries by lessening some of the risk involved in pricing new therapies. Over the last several years, CMS approved around 15 reinsurance type Section 1332 waivers in states around the country, which have had the effect of lowering premiums and encouraging competition in the individual market. And the importance of competition can't be understated because we know that competition among private plans results in more choice and in lower premiums for consumers. In addition to the ideas I've already sort of sketched out, I wanted to talk a little bit about some additional tools that states can use to address obesity coverage. We talked a little bit about EHBs before, but I guess we could talk further and say, it is kind of a barrier for states to go through this lengthy process to make changes to their EHB benchmarks. But a number of states could get together and pool resources and take a look at, what are the best benchmarks. And, Joe had a resource around what an ideal coverage sort of set of coverage items would be for obesity. And that is something that maybe a number of states could get together and work on. We talked about the benefit mandate issue. While obviously states are sort of free to do what they want to do in the large group market when it comes to benefit mandates, in the small group market, there's the defrayal obligation if there is a new benefit mandate. So that's something to consider. In addition, I touched on waivers earlier, but waivers can be powerful tools for addressing really state-specific problems and crafting unique solutions. For example, a state could pursue a 1332 innovation waiver to fully implement value-based insurance design, which is really about incentivizing people to seek high-value, high-effectiveness services over those that are less effective. And I think another thing I'll toss out here is, I think as states look at, crafting unique solutions, for their markets, I think states that have not done so already should consider establishing their own state-based exchanges, because I think, for health insurance, because I think that gives you a lot of flexibility to be able to pull on some of these levers that I've been talking about. There's also wellness demonstration authority in the ACA. And while there's authority to do wellness programs in the large group market and the statute, There is a 10-state demonstration authority for the individual market for wellness programs that can include what are called health contingent wellness programs that, for example, could provide financial or other incentives for people to lose weight, stop smoking, or get into shape. This authority could be used to implement programs at the state level that mirror some of the innovative approaches that we've seen in the self-insured space. And telemedicine, I know, is a big hot topic lately, but when you think about it in terms of rural areas and network adequacy, I think states should really consider looking at telemedicine as a way to access specialty care in circumstances where it's not available, and even include that credit the insurance companies for that in their network adequacy determinations. And then I think something Joe sort of referenced earlier was comes in the area of licensure to make sure that health professionals are able to practice at the top of their license, which could make the difference in a lot of cases, especially again in rural areas or underserved areas, in getting people access to the screening and the treatment that they need. And another big buzzword, obviously, social determinants of health. But if you think about very simple, interventions such as transportation services, and then providing access to healthy foods, and so on, you could really see how that could move the needle. But with that, I'll stop and just thank you again for letting me address all of you, and we'll look forward to your questions. Thank you.
Thank you, all of our panelists today for being here in this informative information. For any of my colleagues who have questions, now would be the time to raise your hand. I don't know how many people are on Zoom, but I had just wanted to start off with a question. So there's some preliminary information that was forwarded along, and it was a flyer that came from the CDC, and I don't know how many of my colleagues received this. And it's interesting because it talks about the Department of Defense and about basically a large population of people unfit to serve, whether young people not able to serve in our military. Obviously, I'm an Army veteran myself, but many young people not able to serve in the military because they were obese, or those people who are currently in the military who are obese at this time. So it's interesting that now the Department of Defense has these flyers. So just wanting to get, and maybe Randy, this question is for you. So where are we with the federal government, and especially the DoD, talking about if this is such a huge impact in our safety and readiness for our nation, what is the DoD doing to have impact on obesity?
So I actually don't know the answer to that, but Joe, maybe.
May I steal?
Yes, sure.
So I think that this issue of lack of people being eligible is one that has garnered attention, right? And you can think back to historically, as we created our food system in the United States and our method of feeding people, a lot of that was actually driven by our military in the early days, as they were talking about our potential candidates to serve in the military were underfed, not overfed, right? And so now there is this group Mission Readiness and others out there recognizing that we do have to change our system. We've also seen some compromise by the military themselves, recognizing that maybe some absolute cutoffs for weight don't make sense, right? If the people are able to perform their duty and be able to do it. But we've also seen them develop, I think, programs to benefit the members of the service themselves, to keep them better on target with their body weights, especially as they age, because most of us struggle more as we age. And finally, one point, and it's worth recognizing because this is something that affects me personally, is that we know that when our military members are deployed, their spouses bear quite a bit of burden. And actually, we see a pretty large increase in obesity among spouses during the time when members are deployed. And so I think it's important that and we see some work both from TRICARE and VA and DoD looking at making sure we care for the families as well, because it is a service member problem, but it is also a family problem. And we don't have perfect solutions, just like we don't have perfect solutions to the obesity epidemic. But I am confident from what I've seen, and actually saw quite an extensive presentation with dozens of representatives from the military there talking about all the different programs they have to try to address obesity, both among recruits as well as their existing service members, that it is gaining attention. There is attention to it.
Thanks. And just one last question before we go to my colleagues. So we always talk about the cost, and it seems that it's hard to get down to an actual number of cost. But we talk about if we let things go too long, it costs more. So is there any way to quantify with a dollar amount? And we don't have the health plans here, on this panel to discuss, what their cost they think it is. But, in dollar amounts, if we cover it now, what we think the cost would be, and I know it would be a large number compared to the long-term effects of not covering, what that cost would be.
Yeah, I mean, I think I was trying to really get at that problem in my comments. And Joe, you probably have something to add to this, but I don't think there is a good number, and we don't really know the long-term cost savings. At least, I don't think the insurance industry has a strong grasp on that. And I think the way actuaries view this stuff, it's really, show me the money. I mean, that's basically how they operate. And so that is a big challenge. And I think, I talked about trying to improve data collection on outcomes and, trying to, pull some of these other levers with risk adjustment and reinsurance, for example, to lower the sort of protect the insurance companies as they price these new therapies, and then they get into coverage is one way to look at it. But I think there's a number of things we can do.
Yeah, I think it continues to be a challenge because of the chronic nature of obesity, right? So it's hard to, do we really truly know the cost of diabetes care and the potential cost savings from that either? I mean, are we asking for something that's impossible to calculate? I think we can do some things short term, but I just, my caution, I said this in my talk, is just to recognize that this is not 40% of people seeking this care, right? This is a much smaller percentage than that. And I think we continue to worry that 40% of people are going to do it. And the reality is that number is probably going to be 5%. Right, and so then that becomes a different cost. Like I've seen, I won't pick on certain states, but I've seen you look at legislation and your scoring folks look at it and say we're going to add this, and they assume 10% or 20% of your population is going to utilize these services, but there's no benefit anywhere that's ever had that kind of utilization when it comes forward. So I just think we need to keep both of that in mind. With that being said, there are all kinds of projects too, looking at long-term costs and looking beyond just healthcare costs too. So if we think about this, the large employer market, most large employers cover the services because they keep their employees a little bit longer. That's why states usually cover it too, is they keep their employees longer, and there's actually a benefit to presenteeism and absenteeism and work performance and things like that. Collecting that data is even more complicated than just collecting the healthcare data.
Thanks. We're going to go to Senator Keith Ingram, please.
Yes, thank you. Is there any state that's, I know North Carolina did some pioneer work with food deserts. Food deserts are tremendous problems, not only in rural America, but urban America as well. And it certainly leads to obesity. Is there any state that has some legislation that's directly affected this and has some numbers, some data to back it up?
So I'll take this one too. And so what we often have with these prevention efforts, right, with prevention in general, which is let's improve the quality of foods in certain areas. That is good for overall health. But prevention is different than the treatment of obesity, right? So we got to be careful on what the expectation is, right? So, the example I use is I'm from Florida. I have to wear sunscreen every day, right? Because of the sun. I don't want to get skin cancer. But if I get skin cancer, I still wear sunscreen every day, but they do something else on top of it. So sometimes I think, so there's great data around food deserts improving fruit and vegetable and other whole food consumption. But there isn't great data to say, well, it directly lowered obesity rates. But I don't think that's a fair assessment of what we're trying to do there, because again, it's not treatment, right? That's actually prevention. And if you're feeding people who primarily already have obesity, that necessarily isn't enough effect. Like for example, like what Angela would deliver to help people, or Dr. Fitch would deliver to help them lose weight. So.
Representative Mesters.
Yeah, Randy, the original comments you made on Obamacare or the Affordable Care Act, is that capturing as well the change in the new subsidies? Because it seems to me that we're going to be looking at a different risk pool if we do a 400% of poverty level, And I'm wondering if we're shifting risk now from the, if you will, the private employee-based plans. You're going to be shifting risk pools where the Affordable Care Act may capture a better risk quality in the portfolio of insured.
So that's a great question. So I specifically didn't talk about the new changes because we don't know the impact yet. I mean, I think, CMS yesterday said there was 2 million, I think, new people have come in during the special enrollment period, with the enhanced credits. But, my presumption is that those people are probably going to be healthier. And, I don't know for a fact. We'll have to see, from the experience. But you think about people that were staying out of the market because of the premiums, that are jumping in. You figure the people that were sicker, are already there. So, but again, with the impact of the pandemic and all the shifts in job-based coverage, I think all this is going to take some time to play out. And I also think that the issue of making the credits permanent, the enhanced credits permanent, is obviously something Congress is thinking about, but has some huge implications for the market going forward that are some good and some bad. But yeah, it's really too early to tell at this point.
Representative Thomas.
Hey, thank you. So just a few short years ago, before I was a legislator, I actually sold wellness plans. And I think employers would do anything to get more participation. But it may be of interest, if this committee wants to pursue this topic, to look at some of the large employers. American Express, JP Morgan Chase, they've done studies. They have data on how obesity impacts their population. And while insurance carriers may or may not, you guys know better than I do, but they have implemented enormous wellness programs, integrated them with their health insurance plans, try to motivate people. And to your point, they still have low participation. They would love to have greater participation. So I do think we have to acknowledge the stigma as a society. Obesity, we have to do what we did with smoking. When smoking became, your kids were like, don't smoke. It became this not popular thing. And we have to move obesity to a place where people know they can get help and can go and get help and get coverage for it. But also we need, as a society, need to kind of admit that. So I do think it's dual edge. And I do actually think there's more data out there that is available, that the employer market has looked at, that they may be able to share with us for us to get a better sense of it on cost. Thank you.
Can I comment? So I just like to say that that's great, and I do agree with you wholeheartedly. I compare it more to mental health issues as well versus smoking, because smoking got a lot of criticism in the UK when they compared obesity to smoke, because smoking is really like a little bit of more of a choice, right, versus a disease. And so I just go back to mental health, where we were like 20 years ago with mental health, when we had very limited medications that were somewhat toxic, if you will, to prescribe. Like, in other words, we had medications that were challenging for providers to prescribe. This is when I started my training in 20 years ago. And then the SSRIs came out, which was a class of medications that were much, had a lot less side effects and a lot less, that were easier for physicians to learn how to do. And then again, we got rid of that stigma, right? That it's about chemistry. It's about brain chemistry and genetics and environment, versus just, some sort of a choice that you're doing.
Yeah, don't disagree. I'm just talking about changing the stigma so that people actually go to get help, because I've seen employers offer and spend thousands of dollars per employee to try to get people motivated. And it's still a challenge to get people to engage.
Right. I do think they're basically messaging it the wrong way, because we're doing it to you instead of participating on this with you. And I think it's going to take a cultural change for us to say, you know what, we're all in this together. Let's address obesity together, right? Instead of blaming that one fat person, right? Which is unfortunately how those come across at times. Not saying all those employers you named, but another one that comes to mind that's spent a lot of time and effort is Walmart recently. I recently saw them give a presentation, remarkable things that they're doing to try to look at this in a different way. And again, some of it becomes not about messaging about obesity, it becomes messaging about overall wellness, right? And that pitch may play better than a direct pitch to just obesity, right? Because obesity is actually the harm that the extra body weight does to your health. So let's address those bigger issues as well. Just a little bit of messaging change might help there.
Right. And if you don't cover medications, as we mentioned earlier, that's the other huge thing, is it only 10% of people will get into that greater than 20% weight loss category with lifestyle. That's just how hard it is to lose weight and keep it off. So if you restrict access to medication and don't give people hope that they actually can be successful, then I think that's a huge, you're saying, let's come do this wellness program, but it's, only going to be 10% effective.
Assemblymember Cahill, that will be followed by Representative Ferguson, and anybody who's on Zoom, if they could raise their hand, we're coming to a close of our time.
Thanks. I'll try and keep this as brief as possible. But Dr. Fitch made me start to think of something else that.
Push the button.
There we go. Dr. Fitch made me think of something else that I didn't think of in my annual effort to take advantage of Randy being here to ask how to use the tools that he talks about to improve healthcare. Mental health parity laws, the mental health parity issue that is being imposed upon the states under the ACA, is that a possible avenue by which we can look to justify or make possible coverage for this condition and other conditions that are otherwise not already covered? That's question number one. Randy, let me throw all three questions out there at once, and then you can take it from there. The next one is more generally about waivers. Have any waivers been outright rejected? Number one. Number two, has any state sought a waiver before they intended to implement it, sort of as peremptory? Oftentimes we'll send a bill to the governor and the governor will veto, saying we can't do this under the ACA. But if we direct them instead with the first piece of legislation to obtain the waiver, then we can come back with the legislation offering the service. Those are my general waiver questions.
Okay, so the last one I think is fairly easy, which I think when you're doing authorizing legislation, you can certainly say, I think the state of Colorado actually did this in their recent public option bill, or one of the bills and one of the iterations. They said, if necessary, they directed the governor to seek a 1332 waiver to implement the bill, basically. So that's certainly an approach that has been used. And then you were talking about waivers that have been rejected. There's only one that's been outright rejected, and that was for completeness determination, and it was actually pretty complicated. The state of Ohio had a waiver that they were required to submit by their state legislature to waive the individual mandate penalty, and that it had already been recently zeroed out by Congress, and so we determined that that was not complete. But other than that, there's not been one that's been rejected. And then you were talking about mental health parity as a model. It's interesting. You think about telehealth parity. People are talking about that as well. I mean, I just would be concerned that again, there's trade-offs involved with all of this, and I think I would rather go at it from more of a aligning the incentives properly and making sure that there's data, because I think insurance companies will cover new therapies if they know they're going to work and they're going to be cost effective. I think it's just a long process sometimes of getting them to do so. And I think using some of these waiver authorities to really incentivize, get people to gravitate towards these high value, high effectiveness treatments rather than some of the low effectiveness, low value treatments, I think is a big part of the solution.
Representative Ferguson?
Thank you. I guess I just had a question about medically assisted treatment. Is that, do they take it for life, or is this like you take it, you lose weight?
So you do take it for life, essentially, just like you would any other disease treatment, hyperlipidemia, hypertension, diabetes, right? And so, again, we also don't have a lot of we have a lot of long-term data on the safety of these medications, but we have not done a lot of research yet into how do people maintain weight loss. That's our next foray as a country, into like what are some of the opportunities, because You know, we've tried, sort of taken the all or nothing approach. Like you go on medication, you lose weight, it helps you to be, you know, helps you to be compliant, it helps you to control that disease state that you're struggling with. If you take it away completely, right, then you get this weight regain. So that's what we know about it, because any intervention you do, you have to do for life. If you do a lifestyle intervention that you're getting from work, if you're using Livongo and it's helping you to lose weight, you have to keep using Livongo usually to help you lose weight. You need that, whatever that intervention is, you need it to continue for you to be successful. And so it's not just a sinus infection where you take antibiotics and it's gone.
I'm sorry if I could ask another question. So in terms of Medicaid, because I mean, I've heard that low-income populations have higher rates of obesity, so that certainly affects our Medicaid dollars. Do you find Medicaid programs more often will pay for medically assisted treatment but not bariatric surgery, or?
No,
it's actually the opposite.
Opposite.
Oh, the opposite.
Yeah,
really?
so we actually have very good data or reasonable data that patients who have bariatric surgery are more likely to leave Medicaid, which I think is ultimately your goal, for them to go back into the employment pool. And so because of the dramatic effect of bariatric surgery, that usually would take people from a disability status or whatever it may be and return them to closer to normal health so they can return to the workforce. So there have been studies published along those lines. But I think in 49 of 51 states, bariatric surgery is covered under Medicaid. And I think that, just ballparking, remember that slide in my head, there's probably less than 20 that cover medications right now.
So is the medication of choice these days, I guess, Trulicity, I guess the shot, is that what you're mostly prescribed? What is the medication of choice?
So Trulicity is a GLP-1 agonist that is not approved for the treatment of obesity. That is approved for the treatment of diabetes. But the GLP-1 agonists are our most potent interventions today for obesity treatment. So liraglutide is approved for obesity treatment. That's the one that I think I mentioned is approved now down to the age of 12 even, which is great. And then the newest one that just came on the market a few weeks ago is semaglutide for obesity, which is called Wegovy. And with that medication, 40% of people are able to lose greater than 20% of their weight. So versus, like I said, with a Weight Watchers type of data, this is good data that comes from these good intensive lifestyle intervention programs. Only about 10% of people are able to lose 20% of their weight. Yet most people come into my office going, I want to lose 50 pounds. And when I say, well, how do you want to do that? They say, I'm just going to exercise and eat less. And the fact of the matter is that only works 10% of the time in 10% of people. And so that's what we have to get the word out on the street, but that's limited by the coverage. And then I mentioned, I mean, I didn't mention this in entirety, but we spend about $200,000 a year in staffing just to do the prior authorizations for our clinic, for our weight center, right? One clinic. We spend $200,000 a year in staffing just because we have to submit this document that says that we know what we're doing and we're treating this patient with obesity. Will you please approve this medication? And then they come back and say, yes, sure, we'll approve it. So 98% of our prior auths get approved because we are only asking for it in people that really need it. Yet we're spending $200,000 a year just to get the paperwork done. And I'm sure the insurance company is spending $200,000 a year as well to process the paperwork. So it's just a lot of healthcare costs because there's this bias and stigma that you have to do something special to get this treatment and you have to jump through all these hoops.
Thank you. I'd like to thank our panelists. We don't have any legislators who've raised their hand to speak, so I appreciate your time here today, and hopefully we'll be able to continue this conversation. And we are adjourning the special session. Thank you.
I'm Neil Breslin, the chairman of this committee, and I would be remiss if I didn't start by saying over this past year, I want to thank, first of all, the industry for being so cooperative and participating, supplying information to the committee, to various states and their commissioners and their staff, also submitting information. And it's been, I think, an arduous and sometimes difficult role to come up with proper and acceptable conclusions and recommendations. But I believe this committee has done an excellent job to get to that point. Representative Lehman, our president, will go into a bit more detail, but today's meeting will be the time that we're able to look at resolutions and pass them. I believe the resolutions listed for consideration during today's meeting represent a strong, effective, and a fair approach to put this committee to rest, or as you might say, to land the plane. The original versions are in your binders, starting on page 180, but since the binder was printed, Representative Lehman and I have revised 2 of the 3 resolutions. A redline version of the amended resolutions are before the committee, and the changes are based on consideration of comments we received from colleagues and interested parties. And again, we couldn't thank you enough for all the input, not only to come up with the resolutions, but to come up with the amendments there too. The first resolution focuses on rating factors and states that NCOIL views as contrary to public policy and unfairly discriminatory the use of all data in the underwriting of private, non-commercial insurance that is related to non-pending arrests, charges, and indictments that do not result in convictions. Second, related to convictions that do not relate in any way to fraud or are not related to the insurability of a prospective or existing policyholder, and urges state legislatures to prohibit its use. Some may ask why we did not include other factors in the resolution, and answer that we do not believe the record is as clear on other factors and that they are not ripe at this particular point in time for action. However, we made it a point in the resolution to note that other factors could be potentially unfairly discriminatory, and NCOIL believes the review of underwriting fairness is one that states should conduct on an annual basis. Don't leave it alone. Review it on a periodic and hopefully at best an annual basis. That leads us into the second resolution, which deals with the use of artificial intelligence, or AI, in underwriting. This is something that has been discussed extensively, even before the committee's formation, and the conversations have only grown in importance and relevancy. While the issue falls beyond the committee's charges, the resolution puts NCOIL on record as, 1, believing that the use of artificial intelligence will surpass the use of individual factors in insurance underwriting, and therefore finds that NCOIL should undertake a review of the use of artificial intelligence in insurance underwriting through the Committee of Jurisdiction over each line of insurance to ensure that such use is not unfairly discriminatory. In other words, the issue of the use of artificial intelligence in underwriting will be something that NCOIL standing policy committees will examine and discuss on a timeline to be set by the leadership of those particular committees. Lastly, this is the longest time in my life I've spoken in front of a crowd other than in front of the New York State Senate. Lastly, the third resolution relates to insurance score transparency. Throughout this process, it has become clear that consumers not only want, but deserve transparency regarding their insurance premiums. Accordingly, the resolution calls for parity in the transparency for insurance scores, with the transparency in the development and usage by lenders and credit bureaus of credit scores. Lenders and/or credit bureaus provide consumers or make available to them with the factors used in the calculation of a consumer's credit score, the weight given to each factor, and when a change in a factor results in a change in the consumer's credit score, we think the same or substantially similar process should be followed with insurance scores. Both we legislators and consumers believe we can understand the credit side of an insurance score because that adjusts in the same ways that our credit score does. But the non-credit side of an insurance score remains a complete mystery to us. We need equal transparency there. Again, this issue also falls beyond the scope of this committee, but many of the discussions before the committee have highlighted the opacity of these factors. The resolution refers this issue to the NCOIL Property and Casualty Committee for further action, including the possible development of a needed model law. Notably, this does not affect in any way the NCOIL Model Act regarding the use of credit information in personal insurance, and the resolution was intentionally crafted that way. The resolution is solely focused on transparency. And with that, I will turn over for comments the President, Matt Lehman from Indiana.
Thank you, Mr. Chairman, and thank you to everyone that's here today. I do want to, first of all, extend a personal thank you to Neil. When this process started, I knew we needed somebody at the helm that was going to have a steady hand, and my first choice was Neil. I called Neil and I said, Neil, would you take the lead on this and chair this? And he said, give me a couple days. I think he called me back in a couple of hours, and he said he'll do it. And I appreciate that, Neil, and you've done yeoman's work here. I also want to thank the industry for their participation. It's been a very open process through the last last year here, and a lot of dialogue and a lot of good dialogue. Thank my colleagues. We've had a good engagement. It's been respectful, but we've heard from a lot of sectors and a lot of different viewpoints coming from those of us who fill the role as a legislator. And then finally, to the NCOIL staff for pulling all this together. I know Will does a lot between Tom and Will, but I know Will does a lot of the legwork on this, making those final changes late into the night and the last night. And so I want to thank them for this. I think that all these kind of combined tell me one thing, and that is that the world of insurance is continuing to change. When I think of, I've been in this industry for 30 years, and I think what's changed in the last 5 mirrors what changed in the previous 25. It is a changing world, and I think these resolutions keep NCOIL relevant, they keep us on the right path, and they keep us focused on moving forward. So I look forward to their discussion and their adoption. Mr. Chair, I'll turn it back to you for Will to call our roll.
Call the roll.
Thank you, Mr. Chairman. Assemblyman Ken Cooley. See, he's up there. I think he's going back and forth between session right now. Senator Travis Holdman. Representative Matt Lehman.
Here.
Representative Joe Fisher. Representative Bart Rowland. Representative Edmund Jordan.
Here.
Representative Brenda Carter. Representative George Kaiser. Assemblyman Kevin Cahill. Assemblywoman Pam Hunter. Here. Senator Bob Hackett. Yeah, I know he just indicated he was on via phone. So, Senator Hackett, are you there? Okay, we'll return to him for voting purposes to confirm he's on later. And Chair Breslin.
Here.
Okay, we do have a quorum, Mr. Chairman. And we're all set. And now if we want to adopt the minutes.
Motion to adopt the minutes. So moved by Assemblyman Hunter. Second.
Second.
Second by Matt Lehman. All those in favor say aye. Opposed? Minutes are adopted. Procedurally, we have a couple of motions now to consider. The first one is that because these amendments in the resolutions have not been given the 30-day notice, we need permission, majority vote to consider them at today's meeting. And I would now recognize a motion to the ability to consider the 3 resolutions. So moved. Second? Second. All those in favor say aye. Aye. Opposed? Motion is adopted. Now I would accept a motion. Oh, okay, excuse me. Okay, we'll listen to each of the testifiers at this point in time. First is from Aaron Collins from NAMIC, National Association of Mutual Companies.
Thank you, Mr. Chairman. Erin Collins with the National Association of Mutual Insurance Companies. Thanks for having me today in person for the first time in quite some time. So nice to see all of you. We really appreciate the work of the committee and the process, as President Lehman outlined, hearing from all sectors. So we really do appreciate that work. With respect to the resolutions before you, we also appreciate the sponsors and the committee being open to our concerns that we've expressed. And although we do continue to have some concerns and think that the language could be improved in some spaces, we do understand the will of the committee to move forward and move on to the committee work that's outlined in the resolutions. So we look forward to engaging with you on that important work on the transparency model. And we're happy to continue to engage in any conversations that the committee wishes to either have here or further down into the committee structure. And thank you again for being so open to all sectors and appreciate the work. So if there's anything else we can do, please let me know, but I'm happy to answer any questions. Thank you, Mr. Chairman.
Thank you very much, Aaron. Next speaker will be Nat Chapo.
Thank you, Mr. Chairman, for the opportunity to speak, and more so for your strong and even-handed leadership on this important issue. And my appreciation also to the entire special committee and all its members. Committee's worked very hard and covered a lot of ground with a broad spectrum of political viewpoints, and which in these positions have been expressed in a detailed, thorough, and open process. And I also echo President Lehman's words about staff. It's a small group, which has given strong support to the members on this very important special committee, while not missing a beat with respect to supporting the rest of the organization. I'll be very brief. I only asked to speak because I submitted a comment letter and proposed language on the first resolution. The committee crafted its own language regarding unfair discrimination. The language, I believe, that you put together and used in the resolution in the end, I think finds an understandable middle ground. And so I commend Mr. Chairman, again, you and the committee for your in-depth study, your open process, and your tangible work products.
The final witness is Karen Melcher. Karen.
Good afternoon, Mr. Chairman. Thank you very much. My name is Karen Melchert with the American Council of Life Insurers, and I'd like to reiterate the comments that have been made to thank you and your leadership and President Lehman's leadership on the important work that this committee has done. I think it's been a very robust process with great input and a lot of time spent, and I appreciate the special dedication we have made to this very important issue. I believe it is your intention to move these resolutions today. Unfortunately, I cannot take a position on them at this point because we have not had time to vet them adequately through our process, which takes a little longer, and we recognize that. But we look forward to a continued dialogue. One point I would like to say, we would welcome the opportunity to have a further discussion on the use of criminal history. We, from our perspective, have not yet presented that, and we do have an extensive approach that we've been working on internally at ACLI, so that may be something we want to consider in the Life Insurance Committee at a future date as we move forward on these issues going forward. I do want to also say that we greatly appreciate the resolution on artificial intelligence to direct that to each line of business and take it from a perspective of that line of business as opposed to a collective approach, because one of the things I think we've reiterated through the many presentations we've given to the special committee over the last year is that life insurance is very different from other lines of business in the way we underwrite and the position from which we come. So we appreciate the distinction on that and look forward to continuing the work that we think will be coming forth in the coming months and years. So thank you very much for your support, and we look forward to continued dialogue going forward. Thank you.
Thank you very much. We'd open it up to legislators if they have any questions.
Mr. Chairman, this is Bob Hackett. I want to just tell you, I am back on Zoom. My phone got disconnected, but I am on Zoom at the airport. So I am good. Thank you.
Recognize that Bob Hackett is present. Any questions among legislators? Hearing none. We have a motion to adopt the resolutions.
So move.
Moved by President Lehman, second.
Second.
Second by Representative Fisher. All those in favor say aye.
Aye.
Opposed? Opposed? Resolution is adopted.
That was a motion to adopt all three of the resolutions,
Yes.
correct?
Yeah. And it's, this will not be the final. We will be doing and studying factors that affect the insurance industry on an ongoing basis. And I think this will be looked at as a model of the ability to, on a continuing basis, to review the conduct and review the changes in the industry to make sure that we have a preeminent position and recognize our consumers first. And with that, that concludes. The three resolutions have been passed. Any additional questions or comments? Senator Cahill from the state of New York.
Thank you, Chairman Breslin. First, I want to compliment you and sympathize with you for the challenge you were given to take this task on. I think when it was first introduced to NCOIL, there was a sense that this was a one and done. But I think what we've learned through this process is that this is an extremely, extremely complex issue and one that warrants continued consideration and perhaps even more aggressive action on the part of NCOIL. And I would urge that consideration be given to you and President Lehman to make this a permanent committee and one that we would continue to look for best practices and look to our colleagues, including maybe this time actually favorably to the NAIC and some of the other things that have been done to recognize that not only are we uncovering the insidiousness of discrimination in so many aspects of society, but that the emergence of new technologies carries with it both the opportunity for more discrimination or the opportunity to correct that discrimination. So for those reasons, I would simply urge that we continue and seek opportunities to be more assertive in this area. And that's about it.
Thank you very much, Senator Cahill from the great state of New York. Any further questions? I'll entertain a motion to adjourn. So moved by Representative Fisher. Second? Second by Assemblywoman Hunter. All those in favor say aye. Opposed? Thank you, everyone, for coming. Thank you for the adoption.
Okay, we're going to call the Joint State Federal Relations and International Insurance Issue Committee to order. Welcome. I'm not Bob Hackett. I'm Jerry Klein. I am the floating chairman. Don't mean it like I didn't get to the restroom, but what we're going to do today, we're going to, I believe Senator Hackett is online, and I'm going to ask everyone, and all the legislators that are attending via Zoom, that they call their names out and where they're from. Bob, are you there?
Yeah, Bob Hackett from Ohio, and I'm only going to be for the first half. Got to get on the plane to get there, so we'll be headed there soon. But I will be on Zoom for the first half of the meeting.
Okay.
Jim Gooch from Kentucky.
Hello, Kim Cooley in California.
Okay.
Hi, I'm Senator Katie Hester from Maryland.
All right, and we will, and the legislators that are here at the table, we have, go ahead, we're just going to introduce everybody so that, go ahead, Paul.
Paul Etke, Minnesota.
Sean Vita, North Dakota.
Randy Burkhardt, North Dakota.
Brenda Carter, Michigan.
Ken Blankenbush, New York.
Matt Pitch, Arkansas.
Steve Meskers, Connecticut.
Roy? And way down on the end? Okay. All right, committee, we need a motion to waive the quorum. Motion from Senator Utke. Okay, second?
I second that motion, Mr. Chair. Ken Cooley.
Okay. All in favor of the motion, say aye.
Aye.
Opposed, no. Motion carried. Okay, committee. I think it's a little difficult, I know, for me to hear the folks that are on Zoom through the speaker system, so we'll try to be careful and listen carefully as they speak. But we're going to begin this with the discussion on the Safeguarding Tomorrow Through Ongoing Risk Mitigation, or the STORM Act. And we're going to start with Rod Scott, who's here with the Flood Mitigation Industry Association. So Rod, if you want to start us out.
I will, and thank you very much to NCOIL for having us in this committee. This is invaluable, this proposed partnership of helping us get state model legislation for the retrofit of buildings in hazardous way. On January 1st of 21, a former president signed into law the STORM Act, which is now law, to provide funds for multi-hazard mitigation. So that would be flood, wind, fire, and earthquake. Hazard risks are one of the largest financial exposures we have in this country. And our portion of that is the flood mitigation of the buildings so that they don't flood. And we can't stop flooding, but we can sure, in our industry, we can sure get the buildings so they don't flood. So next slide, please. So we want to definitely thank our partners. Federal Association for Insurance Reform was instrumental in getting us contacted with NCOIL. Again, we're the industry that fixes the buildings. We are not very familiar with this legislative process. And again, we are eternally grateful for NCOIL's willingness to look at helping draft model legislation for the hundreds of billions of dollars of retrofit in this country, or the changing climate we're going to lose. Next slide, please. Since 1980, 265 weather and climate related events, next slide, please, that have each cost our country $1 billion or more. We're at $250 billion in losses in just that span of time. And every year, last year, my state of Louisiana took 4 hurricanes, direct impacts. My town had 4 floods, but because I'm 86% elevated, I was back in business in a week after 4 floods each time. Next slide. Not only is flood risk increasing, but flood insurance rates on the estimated 3 or 4 million buildings is going out of sight, and is going to continue to reach actuarial rate in 5 years for all buildings except your primary residence, 11 years for your primary residence. If you are 4 feet below the flood elevation of today, remember at the coast that elevation is going to change as the sea continues to come on, you'll be at $9,500 a year. Compute that out at 30 years of mortgage. We have to retrofit our nation. Next slide, please. Mitigation reduces risk. This is what my town looks like now, except for 10 buildings left on the ground. We have to live above the water or dry flood proof our buildings, or we're going to lose. Next slide, please. This is Florida. Florida has an estimated 600,000 of these buildings that will require retrofit or replacement with new construction. New York is 400,000, New Jersey 400,000, Texas 300,000. It goes on and on. 3 to 4 million old buildings. The banks in our country estimate a 1.5 trillion asset value. Our industry can retrofit these buildings, wet and dry, flood-proof them, elevate them. We estimate the cost at about half of that asset value at $600 billion. And we hope to create, with the Storm Act, 1 million jobs in the construction trades within the next 10 to 15 years, or we lose. Next slide, please. In May of 2019, our industry was invited to a closed meeting. That's the Treasury building. During the meeting, we had nothing but banks, FHA, Fannie, Freddie around the table, and I was there to assure them that we could keep up if we had financing. We don't have financing for this. That's the problem. Next slide. At the end, here's the promise. This building is in Key West. Concrete block building, elevated 4.5 feet, went from $3,500 a year to $500 a year in flood insurance. At the end of the meeting, the banks, basically with our reassurance as an industry, told the Treasury that if a loan became available, they could loan the federal government the $600 billion that we would need to mitigate these 3 to 4 million buildings. Asset value at 1.5 trillion. Next slide, please. So the Storm Act, we have to create a revolving loan program at the state level. And then we're going to have to create a revolving loan program with NACO's help, is next, at the taxing authority. We must have a restricted fund within these programs to keep the extreme external forces of the traditional construction and basically the levee and drainage contractors, the traditional infrastructure for mitigation, hands off this money. The banks are not going to loan us this money if we don't protect that money just for the buildings. That's their business, is buildings. They are not interested in loaning us money for our other infrastructure, which we do need to revenue bond or find other ways to fund. And I remind people that 50 cents out of every tax dollar from a property goes to a school. Next slide. Today's presenters on our program are the authors of this legislation, Mississippi River Cities and Towns Initiative. 10 states along that mighty river got together, got their senators and representatives together, and they passed this bill that we've been trying to figure out how to do, only it's multi-hazard, by a voice vote on the last day of the 116th Congress. It was amazing. I watched it on the internet. Maryland Senator Katie Fry Hester, the sponsor of the 2021 legislation that passed in Maryland, their state revolving loan program. It has become now a cornerstone of our draft legislation, and we have some improvements and different ideas to add to that original legislation. Their legislation was kind of created as a result of that giant brick program coming from FEMA. We want the bank money to come in and go to the property owners. And then we have this whole issue of low income. We have 300,000 low income family housing units in the flood zones in this country, the least able to recover in the most vulnerable of our populations. And in service related areas of tourism, we've got to have our low income people near the tourism businesses. And then Tom Little will hit cleanup for us. He's a VP of floodproofing.com, which is a leading company in the flood mitigation industry. They have become vertically integrated from doing just flood vents to selling flood insurance, private and NFIP, as well as a whole host of flood mitigation products that they now sell, which wrap the buildings, close the closures. It's a growing industry. So I'm going to kick it off to Colin Wellenkamp, who should be on our Zoom, who's coming to us from the Mississippi River today. Colin?
Thank you, Roderick. Can everybody hear me okay?
Yes.
All right. Can everybody see me okay?
Yes.
All right. All right. Good afternoon, everybody. Thank you, Roderick, for that introduction. My name is Colin, as he mentioned. I'm the Executive Director of the Mississippi River Cities and Towns Initiative. I am on site today in the field, even though I may not appear to be dressed for it. So I do apologize for any background noise. There might be a little bit, as there's a ferry near me just over here that goes back and forth. So you may hear that in the background a little bit. Situated behind me right here is the mighty Mississippi River. And just out this way, directly toward my hand, tips of my fingers, is Grafton, Illinois. I'm on the Missouri side of the Mississippi, and Grafton is right across there. Situated in Grafton today because Grafton, Illinois is really a poster child city. Actually, this entire region of the Mississippi, which is near the confluence of the Illinois, Mississippi, and the Missouri rivers, just north of St. Louis, is a poster child region for repetitive loss and the need to build resilience into our infrastructure and our economy. When our mayor sat down to draft the original version of the Resilience Revolving Loan Fund, or what came to be known as the STORM Act by the Senate label and then passed into law, this is really what we had in mind. We had flooding, droughts, intense heat, named storms, and unnamed storm events that had been impacting and continue to impact our region along the Mississippi River at a record level with record persistence. We're now averaging brand new records every 24 months in both extreme heat temperatures, duration of those temperatures, and floods. The last big moment we had was not too long ago, 2019, a 270-day flood, largest and longest in U.S. recorded history. That flood took place from Pennsylvania to Oklahoma, southern Minnesota to New Orleans. It was truly a basin-wide event implicating almost all of the major tributaries of the Mississippi River, 8 months in duration, cost us over $20 billion in actual losses. And that flood just comes on the heels of lots of other ones preceding it. The 1,000-year flood event in the South of 2016, the flood of 2015, the flood of 2011, the drought of 2012, and then, of course, all the hurricanes spattered in between. So we could go on and on with that. But what we're really trying to do is get away from impacts and the very expensive end of the balance sheet of dealing with recovery and response. Instead, dealing with mitigation, adaptation, and resilience, which actually saves us up to $12 for every dollar we put into it for the economy. So we think that that end of the balance sheet, mitigation, adaptation, and resilience end, is a much safer bet. Apparently, so does Congress. Not only did they pass the Resilience Revolving Loan Fund Act, or STORM Act, but they've also put in upwards of $500 million of new investment into resilience, taking that away from the very expensive activities of response and recovery, and hoping that if we invest before that, we won't have to get to that those very expensive steps. Now, we are an association of 101 United States mayors through all 10 states, and we're currently led by the mayors of Baton Rouge, Louisiana, and Bettendorf, Iowa. We're headquartered in St. Louis, Missouri, and I'm not too far from that right now. If you can imagine, in 2019, everywhere where I'm standing right now was underwater. In fact, I would be underwater right now if I was standing here in spring, early summer of 2019. It would be a couple feet above my head, as a matter of fact. And in 1993, it would be even further above my head. The city of Grafton, just across the way from me, received significant inundation. In fact, in 2019, they got 80% of their economy wiped out by that flood. Many of our cities did. And then came COVID to top it all off. So the Resilience Revolving Loan Fund was a way where our cities could accomplish a few things. One, we could get out of this cycle of having to apply to grant after grant after grant on the federal level. Most of the time, we are not successful in getting those grants. they're extremely administrative heavy and they're expensive to apply for. Most of our cities don't have the capacity or expertise to really do that credibly. So get out of that cycle. And the other thing we wanted to do was figure out a way where when we invest in a resilience project, that investment actually goes to the next resilience project, that these projects aren't separated, but they build on each other, and not only build on each other's capacity and physical attributes, but also build on each other financially. So the revolving loan fund model seemed like a good way to approach that. And thirdly, we really wanted to figure out a way where we could incentivize projects that concentrate not just on the built infrastructure, but the natural infrastructure. I'm actually standing right here in the middle of floodplain that isn't developed. And right across from me, right here on the other side of this island, Grafton, Illinois has installed a wetland. It used to be there, it was destroyed long ago, and they're putting it back in order to create a natural flood buffer for their city. Just up the way here, and I'll pan a little bit so you can see upriver. Just in this area up here, upriver, we're actually putting in more floodplain, more habitat, more backwater areas that are linked up with a partnership with Ducks Unlimited to naturally take in risk and absorb impacts from climate change and disasters before they even get to our cities, and then let those impacts go at a managed level over time after the storm, after the disaster ebbs. That natural infrastructure is actually called out as a priority in the legislation, in the Resilience Revolving Loan Fund. And as Roderick said, a lot of this is to protect our built environment. The buildings are the most expensive implicated infrastructure from all these disasters. And it's hard for us to be able to finance any other solution that might be hard structure. So levees, flood walls, and other brick and mortar infrastructure to stop these disasters is really outside of our financial capacity. Not only could we not afford to build it, we wouldn't be able to afford to maintain it either. So natural infrastructure actually is the only solution we can afford. And the beauty of it is it comes with ancillary benefits, and we don't have to pay to maintain it. A wetland, a marsh, not only do those things buffer disasters, they also clean our water, and they regulate water in dry periods when the river's very low in order to keep navigation more reliable. And it's just as hard to get to a flooded elevator for grain as it is to get to one that has no water around it at all because of a drought. Natural infrastructure can help us regulate that much more efficiently and regulating a lot more water than we ever could with pipes and pumps. Also, natural infrastructure is a tourist draw. People pay to look at water, but they don't want to pay to look at dirty, smelly water. So the burgeoning cruise industry, the outdoor recreation industry, the tournament fishing industry, all are helped by increased ecology and natural infrastructure because they create draw for those tourism and outdoor recreation dollars. Finally, we're using this water for a heck of a lot of manufacturing. So we need it fresh and clean all the time, and we need it freely accessible all the time in order to power that huge, massive manufacturing economy on the Mississippi River. All told, our corridor enjoys a $456 billion freshwater economy. Well, we need clean fresh water to keep that happening, and we need a reliable system that's ecologically healthy and economically backed up, supported in order to keep all of that economy going. So the Resilience Revolving Loan Fund, we think, is another great tool in the toolbox to help make that happen. States are key. So this is going to be a partnership between the federal government, in this instance FEMA, state emergency managers, and localities, cities and counties. When the Resilience Revolving Loan Fund applications hit the street, which we hope will be in the spring, early spring, there will be an opportunity for states to compete for a capitalization grant from FEMA to form this Resilience Revolving Loan Fund within their states that our cities can apply for projects. But the administrative lift in all of this is purposefully kept light so that the projects themselves really fly or don't fly, sink or swim, on the merit of the ability to repay the loan. We like that much better than the administrative lift that comes with traditional FEMA grants, which is usually out of our reach. So I'm going to leave it there. Happy to answer questions, concerns that folks may have. I want to thank NCOIL for inviting us, and Roderick, thank you for putting this together.
Thank you very much. Appreciate it, Colin. Now we'd like to hear briefly from Senator Hester, the author in Maryland of the first state revolving loan program for resilience. Senator Hester.
Thank you so much, everybody. It's a pleasure to be here. I did have a few slides. Are you guys able to show those?
Yes. Yes. You have those slides?
Well, while they're bringing the slides up,
Hang on. I'm trying to get them up, Senator.
yeah,
Hang on.
that's fine. Take your time. I'd also like to acknowledge my amazing partner, Delegate Watson, who's in the room with me. We were both elected in 2018 and put in several pieces of resilient legislation aimed at resilience together. So if you have any questions, feel free to approach her if you're there in person as well. She's an expert on all of this stuff.
Do I click the clicker for this?
Could you repeat that name? I didn't quite catch it.
Yes, so it's Delegate Courtney Watson.
And if I could make a request, if you could speak somewhat slower, just because the speakers are kind of with a lot of feedback, it's hard to hear you.
Will do.
Can we have the first slide up for this program? We're getting some technical assistance here. Hang on, Senator. Sorry.
No worries.
We were just on the Mississippi River, so we got to get you programmed up here. Thank you again for sharing your story with us. It's incredible that a state already did this. It is a model for us.
Well, when the slides come up, the first couple slides you'll see will be about Ellicott City. And Ellicott City is in my town, and probably many of you have seen it on the news. It will celebrate its 250th birthday this year. And in July of 2016, we suffered our first 1,000-year storm. It dumped over 6 inches of rain on the hills around Ellicott City in less than 90 minutes. And the result was a flash flood that caused an estimated $11 million in damage and took the life of 2 of our community members. And I can't underscore how much the psychological trauma of the residents and business owners of Ellicott City, suffered in addition to that, monetary damage. But we rebuilt, and in 2018, the stores reopened, and life was coming back to normal. And then we had our second 1,000-year storm in May of 2018, which is less than 2 years apart. That storm dropped 8.4 inches on Ellicott City over the span of a couple of hours. And this time caused $27 million in damage and took the life of another one of our community members. So from personal experience, we can tell you that climate change is real, and resilience is the key to success.
And we are having some problems, so if you could continue, we will try and get some slides up.
Okay, I'll keep going. So in addition to Ellicott City, Maryland is a coastal state, and we suffer flooding all over the place. Ocean City, is of course a great tourist destination, and that repeatedly suffers flooding, as does Annapolis and Baltimore. And so, having experienced the flooding firsthand, but then also thinking about the state as a whole, we really started to look for a statewide solution. What I found, working both with my county executive and also with our local emergency managers, is that the major barrier to rebuilding after a flood was the cost, let alone trying to build before a flood to prevent, future floods. This financial barrier that the first speaker talked about, is real at every level of state government. So I think I can see my slides. There's the one that you're on right now is Ellicott City, and then there's Ocean City, Annapolis, and this is the slide I'm on now. What you're looking at is a map of Ellicott City. And just to explain the complexity and the financial cost associated with building back, those little red dots on the slide, they each represent a resilience project. There's 19 in total. Some of them are retention ponds. Some of them are culvert expansions. There's a bypass pipe that is over 9 feet wide on the western side of our main street. There's also a 10-acre retention facility proposed off Roger Ave. And then, of course, the kind of pinnacle of this safe and sound plan is the 15-foot diameter tunnel bore that is to be drilled through the South Hill of our historic district to create a shunt from the top of the hill directly to the Patapsco River at the bottom. And so such large scale infrastructure is now possible, but of course it costs money. And to implement all 19 pieces of the Safe and Sound plan is projected to cost $140 million. Now, for a small municipality, like Ellicott City, this is dependent on our ability to pull money down from the state and federal level. So throughout this process, I was looking, for capital in our state budget, and then capital at the federal level. And that's originally why I was interested in FEMA's Building Resilient Infrastructure and Communities grants. And so I was beyond thrilled to learn that round of funding would be coming again as to allow states to protect their communities, especially those like mine. And so we were in the process of figuring out how to leverage the BRIC funding when we came up with a legislative solution to fill that gap. So you won't be able to read this slide, but let me just, explain. This is the actual legislation that we drafted. And ironically, we came up with this idea to create the Resilient Maryland Revolving Loan Fund. We modeled it after the state's Clean Water Revolving Loan Fund before we had even heard about the Storm Act. We had been studying infrastructure banks and impact bonds for several months. And in December, before our legislative session, we had settled on the idea that a revolving loan fund to assist our local jurisdictions for that local match to the BRIC fund was what we needed to get the finances flowing. A week later, the federal government passed the Storm Act. And so we rewrote the legislation and submitted our bill in the current form to incorporate and prime the bill to accept the money that the Storm Act makes possible. So Senate Bill 901 establishes the Resilient Maryland Revolving Loan Fund. It sits within the Maryland Emergency Management Agency, which now is known as the Maryland Department of Emergency Management, for the purpose of providing low or no interest loans for local resilience projects, either through a local government or a nonprofit. The fund is a special non-lapsing fund, so the money that's held in it does not revert to the general fund. Additionally, there's uncodified language directing MEMA to apply for funding through the Storm Act to capitalize the fund as soon as the funds become available. So when you see the legislation, you will also notice that there was $25 million of state funds that we put in the original bill to match the Storm Act. Those funds were later removed because we put the $25 million in the capital budget in order to secure those through the capital budget process. And actually the budget passed before the legislation did. So when I was defending the bill, I said, listen, you've already passed the money. Now we just need to create the fund. But the $25 million of state funding will allow us to draw down $225 million through the Storm Act. If you're able to go on to the next slide, this is how the leveraging could work. Hypothetically, loans from the Maryland Revolving Loan Fund, local governments can pull down $750 million of federal BRIC funding for a total inflow to the state of $1 billion. Now, this is obviously best case scenario, but I'll break it down for you. The $25 million of capital funds gets matched 90-10 the Storm Act. So that turns into $250 million. Then the BRIC funding grants are 3-to-1. So if a county, like Howard County had a $10 million loan, they could pull down $30 million in a grant through BRIC for a total of 40. And that's how you get to the $1 billion. On my last slide, I just wanted to share a few of the keys to success. The first key was really the broad impact of flooding and natural disasters in Maryland. Unfortunately, or fortunately, all of my colleagues in the Senate and the House, in every single person's jurisdiction, they had experienced flooding, and they knew that they could save money by building the resilience of their towns and communities first. So there was broad support for the idea that we could do something. Secondly, the availability of these federal funds made a huge difference in our ability to press the legislation through in 1 year. It's just so much easier to explain the value proposition to the Budget and Appropriations Committee when there's federal money on the table. And finally, I had excellent partners. I couldn't have gotten this done without very incredible partners, including our treasurer, Nancy Kopp, who's been a true advocate for climate change and resilience legislation over the years. Of course, the Capitol Chair, Senator Doug Peters, was instrumental in moving the $25 million into the capital budget. And Senator Guy Gazzoni, the Chair of Budget and Tax, and Delegate Chair Maggie McIntosh, they were all believed in this as well. And then when it came to defending the bill in the House, Delegate Courtney Watson and Delegate Stein were incredible partners to move it through the House. I really want to applaud leadership, our Senate President, and also the Speaker of the House for their role in this. I really feel that the timing was right, the federal tools were there, and there was political will to move boldly forward. And so delighted that this has passed, and now we're just waiting for the capitalization of the first Maryland Revolving Loan Fund. Thank you.
Thank you, Senator. And finally, we have Tom Little, who's Vice President of floodproofing.com. Tom, you're going to have to speed it up a little bit because we have two other presenters, and I know you had quite a few slides, but if you could briefly go through your slide deck, and we need to get on to the two other presenters. Tom Little of floodproofing.com.
Well, thank you, Rod, for having me, and the rest of the folks of NCOIL. I'm from New Jersey, so speed's my middle name. So I'll do my best here to get this moving. I have some slides as well. Are they gonna be pulled up, Rod, or should I pull them up on my screen?
We're ready? Oh, he'll put them up. Tom, you can share. You're ready to share screen.
Okay, let me see. Yeah, I'm sorry. From my end, it's not allowing me to do it. If you could pull up from your end. If not, then I'll just go over my topics.
I guess he's having problems sharing from his computer. Sorry about that. Hang on just a second.
Have him go over it.
Okay, why don't you just run through your topics, Tom? And we do have two other
Absolutely.
presenters we've got to be considerate of here.
No problem. So we're an example, our organization, and we have a portfolio of companies that are all laser focused on solving flood problems. And we started our journey in flood protection, mitigation, back in 1997 with the development of a product called Smart Vent. It's an engineered flood vent that is designed to relieve pressure, hydrostatic forces against the foundation wall. Those forces can cause the foundation to collapse, and it does a number of things. Causes significant structural damage, which translates into a flood insurance claim, if in fact they have flood insurance, the owner that is, but also it displaces the family. Same thing on the commercial side. There's vulnerabilities when floodwater comes through the doorways or the windows and other penetrations of a commercial building that can shut the business down. So at a very high level, when we solve problems, our mission is to keep families from being displaced from their homes and commercial businesses to maintain business continuity, keep the lights on at the end of the day. So we started with this flood vent product in 97, but we realized that there was other needs within the industry. And part of the introduction that Rod provided in the beginning explained that we have vertically integrated over the years. Today, we have 5 companies within our portfolio that handle flood protection with wet flood proofing techniques like a flood vent, dry flood proofing techniques, barriers and shields from preventing the floodwater from getting into a building. And then we pull that all together with a company that sells flood insurance nationally. The National Flood Insurance Program, we provide that to our customers, but we also have worked with the private carriers within the industry to provide their products and coverages in certain situations. It was mentioned earlier that every dollar spent in resiliency or mitigation can translate into $12 in actual savings, disaster savings. And what we are experts at are the buildings and the homes. We are direct with those building owners. We are direct with those residential structures. And so we're working on a level where we would utilize a revolving loan program, or our customers would, to be able to mitigate their particular property. So part of our evolution has been that we have developed strategies and techniques that will mitigate just about any structure in the United States, residential and commercial. And we've developed a service called the Flood Design Team, where we're capable of doing a vulnerability study at the structure level to determine what type of techniques can be utilized to mitigate the risk. In some cases, it's utilizing flood vents with elevated structures like Roderick mentioned in the beginning of the presentation. The flood vents would go around there to relieve the pressure and potentially save a $35,000 plus claim if in fact pressure would build up, it could collapse that wall, right? So we're preventing that. Likewise, on a commercial structure, we have ways to put barriers and shields in place to prevent the floodwater from entering into the building. Some of those are deployable systems, which need human intervention, but we've developed an innovative technology that allows you to do that passively. In Maryland, Ellicott City was mentioned. We're actually working in that historical district area with passive flood-proof window systems that go into a building that are much like your set it and forget it. The glass is actually flood-proof, and can take an impact and up to 10 foot of floodwater pressure against it and keep the inside of that building dry. So innovation, we employ our particular group of companies, we employ 40 individuals. We feed 40 families is the way that we look at it. And then we also have manufacturing lines for our products that are all made in the United States, that we deploy another 20 folks on those lines by building our products in the US. Scalability is there. We can manufacture more product. We can protect more homes. We can protect more buildings. That comes down to the families and the economic side of items as well. If this funding were to actually be in place. Lastly, I wanted to just share a quick story of a property owner in Peoria, Illinois, along the Illinois River that we helped out 5 years ago. He's a 28-year veteran of the Air Force. He purchased this home. It was in a floodplain. It was an elevated home. His flood insurance premium was on the rise, and it was getting to the point where he was not going to be able to afford to stay in the home because he could not afford the flood insurance. He spent 2 years trying to figure out a way to lower that premium, save the house, contacted us, and in 5 minutes, we determined, Mr. Wagner, the solution to your problem is retrofitting 5 flood vents into the perimeter foundation. The NFIP provides you with a flood insurance discount in your scenario if you do that. They put the 5 flood vents in. It reduced the premium 75% from $2,500 down to $500. The return on investment was instantaneous in his situation. He didn't have the money to actually purchase the vents, so we provided them to him until he got his refund back. Since that installation, he has flooded 5 times and has had 0 NFIP claims, suffered no structural damage, is still in the home, and was recently able to marry his daughter at the house, which he was so super proud of, and sent a video of the vents as he walked by to show where he was going to marry off his daughter, to thank us for what we had done to help him financially, but then through those 5 floods. So that's what our industry can do. We can keep these folks and these families in these homes, lower their premiums with this mitigation that the NFIP recognizes, but the private sector recognizes. And we can do it both residentially and commercially on the building level with a revolving loan program. So again, I thank you for your time.
Great, Tom. Thank you very much. I'm just going to wrap it up here and thank the NCOIL again. Look forward to hopefully the meeting in November in Scottsdale. Hopefully you'll all find that this is a worthwhile project to complete, and we're looking forward to getting legislation introduced into states in January of 2022 to continue this progression towards financing this STORM Act. Thank you very much for your time, and I'll hand it over.
Okay, I think we're going to pick up Tony. Tony, are you out there?
Yes, sir, I am. So,
go ahead.
One issue. Okay, thank you very much. Let's see. Good afternoon. It's great to be here today to talk to all of you about, sorry, technical problem. Here to talk to you about the NFIP program's new pricing methodology, what you will probably know as Risk Rating 2.0 Equity in Action, and what the new system means for your constituents and other interests that may be connected to the National Flood Insurance Program. And I've been listening for the past half hour or about an hour. So there's a lot of linkages to this and probably much interest in it. So FEMA still believes that insurance is the best defense for flooding of all property types. Can you change the slide, please? I'm sorry, I'm operating from a laptop and I'm out actually in the great state of Maryland, near Antietam Battlefield today. So I was trying to be there in person, but there were too many things going on with the office, so I couldn't. So back to my presentation, I apologize. Equity in Action is a transformative effort that will help FEMA achieve its mission and pursue equity in pricing for all of our policyholders. As you are well aware, rates already increase under the current NFIP methodology, and respectively, under Risk Rating 2.0 Equity in Action, rates are going to increase for some policyholders, and also rates will decrease for some policyholders. I'll talk about this a little bit later in my presentation. So policyholders who will see increases under the new NFIP pricing plan fundamentally differ from the rate increases under the current rating methodology. And as I said before, currently all NFIP policyholders have been subject to premium increases every year. From 2018 to January of 2021, the average annual premium increases under the current methodology have been around 10%. These yearly increases are in line with the statutory limits required by Congress and would continue to occur year after year after year for all policies if no changes were made. However, under the new pricing methodology, rate increases will not continue indefinitely. So once a policy reaches its full risk rate, the increases stop. So it's important to note the new plan will comply with all statutory and regulatory requirements, including premium caps currently in place. So under Equity in Action, 2/3 of all the older homes, which are currently paying some of the highest rates in the NFIP, will see immediate premium decreases. So later I'll speak a little bit more about what those changes look like across the nation. So next slide, please. So this change will address the inequality in the program that has inadvertently developed over time, and it must be corrected. That is, policyholders with lower value homes are paying more than they should, and policyholders with higher value homes are paying less than they should. So the new pricing plan enables FEMA to set rates that are fair and ensures rate increases and decreases are both equitable. In fact, like I said before, we've learned 2/3 of the older pre-firm homes that have some of the highest rates in the NFIP today will see immediate decreases in the cost of their insurance. So the new rating methodology has exposed these inequalities, and we cannot turn a blind eye to our policyholders who have been unjustly subsidizing other policyholders. So in addition, because our rating methodology hasn't been updated in more than 40 years, it's not fiscally sustainable in its present form to withstand the frequency and intensity of recent events and the storms that we know will strike in the months and the years ahead due to climate change. So FEMA has the statutory mandate to set actuarially sound rates and clearly communicate that risk. It's a well-known fact that FEMA has been urged for many years from many quarters to improve their pricing methodology. Our current system is just fundamentally not working for the program or our policyholders and must be revamped. While difficult, now is the time. Next slide, please. So since the 1970s, rates have been primarily based on rather static measurements, emphasizing a property's elevation within a flood zone on a flood insurance rate map. This approach does not incorporate as many variables as the new methodology. As such, the new methodology is not just a minor improvement, but a transformational leap forward. Under Risk Rating 2.0 Equity in Action, FEMA now has the capability and tools to address rating discrepancies by incorporating more flood risk variables like flood frequency, multiple flood types from river overflow, storm surge, coastal erosion, heavy rainfall, and the distance to a water source. along with property characteristics such as elevation and the cost to rebuild. Now that the new methodology takes into consideration the cost to rebuild, FEMA will be able to equitably issue premiums across all policyholders based on the unique risk of their flood property. So previously, it was done by a zone. An AE zone across the nation was all treated the same. So we know now it's going to be unique based on that individual property. So equity in action will be building on years of investment of flood hazard information by incorporating private sector data sets, catastrophe models, and evolving actuarial science. This includes using existing FEMA mapping data and NFIP policy and claims data, along with federal government data from the USGS, NOAA, the U.S. Army Corps of Engineers. In addition, third-party commercially available structural and replacement cost data, along with CAP models, is incorporated. This approach is clearly a significant improvement and allows us to set actuarially sound rates and communicate the flood risks more comprehensively than ever before. Next slide, please. So let's break down what risk rating in action, equity in action really is into 3 buckets. And those buckets are what's staying, what's going, what's changing when it comes to the new pricing methodology. First, it's important to keep in mind that Risk Rating 2.0 Equity in Action is really about changing how we rate premiums. So what it doesn't do is make changes to the policy forms or the coverage policyholders will receive. In terms of the policy forms, as you'll see, there are 3 main types of forms right now: dwellings, general properties, and residential condominium building association policies, or what we call RCBAPs. They'll continue to exist under the new methodology. However, you may notice there's a couple of minor changes to those forms, but it's important to note that those changes are in respect to legislation FEMA is implementing as part of the Bigot Waters Act. In terms of policy coverages, there will be no change. For instance, a single family home policy continues to have limits of $250,000 for the structure and $100,000 for the contents. Next slide, please. So Risk Rating 2.0 Equity in Action is transformational, but it's not changing every aspect of the NFIP. We're upholding the statutory requirements by limiting annual premium increases. The existing statutory limits require that most rates not increase or climb by more than 18% per year. We're also maintaining the use of the flood insurance rate maps for mandatory purchase, as well as floodplain management purposes. In addition, we will continue to offer premium discounts for pre-furnished, subsidized, and newly mapped properties, as well as policyholders will still be able to transfer their discount to a new owner by assigning their flood insurance policy when the property ownership changes. Furthermore, discounts for policyholders in communities that participate in the Community Rating System, or CRS, will continue. Communities will continue to earn the National Flood Insurance Program rate discounts of 5 to 45% based on their Community Rating System classification. However, a point to note, since Risk Rating 2.0 does not use flood zones to determine flood risk, the discount will be applied uniformly to all policies throughout the participating community, regardless of whether the structure is inside or outside the special flood hazard area. Can we change the slide, please? So what's going? So under Risk Rating 2.0 Equity in Action, preferred risk policies will be rated similarly to how FEMA rates all other policies. You'll see this phenomenon more generally with how we rate. Since FEMA will be able to differentiate flood risk in areas outside the high-risk flood zones, there will no longer be the need for the agency to offer preferred risk policies. Also under the new methodology, coverage and deductible limitations will no longer be limited for PRPs. For instance, today, a single family home PRP policyholder can select $200,000 in building coverage and $80,000 in contents, or $250,000 in building and $100,000 in contents, and no other options. Under risk rating, oh, excuse me, I'm a little cold. Under risk rating 2.0 equity in action, they can select limits and deductibles like any other standard flood hazard policy. Furthermore, under the new methodology, FEMA will no longer, FEMA will no longer offer the mortgage portfolio protection program since it is rarely utilized. This is a perfect example of FEMA's mission to align with our modern data principles to simplify things where it makes sense. So additionally, under the existing methodology, flood zones are the main driver of the rate, as I've mentioned before. This is not the case with risk rating 2.0 equity in action. For the most part, the flood zone is not used in rating under the new methodology. And I'm talking about the rating. But there are a couple of places where you're statutorily required to use flood zones under risk rating 2.0 equity in action. And they include AR zones, A99 zones, and newly mapped zones. Also, under the new methodology, it's important to note that the base flood elevation will continue to be used for floodplain management purposes, but not for insurance rating. So there are two reasons for this. First, we're using nationwide, and BFE doesn't work nationwide. And second, we are looking to simplify our program and use concepts that the average agent or policyholder can understand. And we think that ground elevation is easier for people to understand than an unseeable base flood elevation line. Next slide, please.
Tony, we
Yes.
are kind of getting up against the clock here. And if you could kind of hit a few more high points, and if there's more information, I think we can even add this to the November meeting. But if you could move along.
Okay, let me
really, thank you.
pull you to, I'm going to move you forward. Let's see where I can get you up to. Let's move up to slide 15, if we can do that. So I just wanted to also say it's important to note that even when policyholders paying the most today will see significant and immediate decreases when they transition to the new pricing plan. Broadly, over 1 million policyholders will see decreases, and this includes 600,000 single-family homes. At the extremes, 3,000 family policyholders pay premiums from $12,000 to $45,000 a year today under the current methodology. These policies are located all across the country. Again, under this process, the existing rating, these premiums will continue to increase year after year. But the big thing with risk rating 2.0 is there's an upward bound put on these policies. No single family homeowner will pay any more than $12,125,000 in a premium. That sounds high, but today some are paying $45,000. So next slide, please. And I'll jump as we can go along. I wanted to hit this. Let's take a quick look at the national analysis for structures in the NFIP's book of business. This includes single-family homes, non-single-family homes, levied, non-levied, for all 5 million policies across the 50 states and the District of Columbia and the territories. Here's what the new data tells us. 23% of current policyholders will see immediate decreases in their premiums. On average, this will be $86 per month and $1,032 per year. That does not happen under the current rating system. The next two categories you see, 66%, the light blue, will see an increase of $0 to $10 per month. But keep in mind what I said before, under the current system, there's a 10% increase annually, which equates to $8 per month under the current system. So this 66%, the change is for some, it'll be $2 a month. So the impact between the old and the new is minimal. Then there's another 7% where you can see there's a $10 to $20 a month increase in what they're paying. this analysis of the new pricing, we had eliminated those steep gaps and those sharp increases that caused a lot of uncertainty with these folks. And then finally, there's 4% of the NFIP policyholders who will see a $20 or more monthly increase in their premiums. It's important to note, though, these policies cover high-value homes in high-risk areas. So let's jump to the next slide. I'm just jumping ahead.
And Tony, if you could, if this could be your final slide, I guess we are nearly out of time and we still have another 2 presenters. So
okay. Yeah,
if you want to just give a final statement, thank you.
Yeah, I'll give a final statement that, you know, during the hearing, we've had many senators bipartisan support for risk rating 2.0. We've had, you know, numerous state flood insurance commissioners support it. And we've had direct support from NAR, the National Association of Realtors. They support it officially, as well as the Pew. So that, I'll just end it there. And if there's any questions, folks can submit them to FEMA. And if we need to spend more time with this in the future, I look forward to doing that.
Well, I don't think this issue is going to go away. I think there's a lot of discussion. I think we're right on the cusp of a lot of new innovative thoughts and ideas. So with that, thank you. And we're going to continue this discussion certainly in the future. And with that, we're going to switch gears quickly. And we're going to hear from Catherine. Are you online?
Yes, I'm right here.
All right, Catherine, go ahead.
I'm talking about the Protect the Right to Organize Act, which has nothing to do with floods. I just want to make sure you know that.
I think we're aware of that, and we're kind of, yeah, we're keeping our heads above water.
Okay. Thank you very much. I'm delighted to speak to you. I was asked to describe the provisions and the possible impact of the Protect the Right to Organize Act, which was passed by the House of Representatives in March. It's currently in the Senate. It is unlikely to be passed unless the Senate is to eliminate the filibuster. But let me tell you what it would do if it were enacted, and happy to talk about what impact that might have for the issues that concern you. To be clear, the PRO Act, as it's called, covers only the right to unionize, bargain collectively, and engage in work-related protest in the private sector, would have no impact on government employment, and it would have no impact on federal or state regulation of wage and hour law, workplace safety, unemployment insurance, or discrimination. The only provision it has that really has nothing to do most immediately with unionization is that it would significantly revise the Federal Arbitration Act, which is the federal statute that allows employers to insist as a condition of employment that individual non-union employees sign agreements to arbitrate all disputes arising out of the employment relationship. The PRO Act, if enacted, would prohibit mandatory, that is forced, pre-dispute arbitration agreements broadly in private sector employment, which of course would have a fairly significant impact because many businesses have adopted such pre-dispute arbitration agreements as much as a way to prevent employment claims from being filed as a way to channel those that exist into arbitration. But focusing on the union side of the PRO Act, it would expand the number of workers who are protected by federal labor law. It would, for example, make low-level supervisors, think of a barista at Starbucks or a clerk at a convenience store, who now can be characterized as supervisors and therefore not covered by protections of labor law. It would make those workers employees eligible to vote in union elections, protected against retaliatory firings if they supported or opposed a union election. In addition, the PRO Act would expand the number of covered employees by narrowing the definition of who is an independent contractor. You may have heard that many states use what's known as the ABC test to define who is an independent contractor exempt from state unemployment insurance protections, for example. But there's been a lot of controversy about whether the ABC test should be applied outside of the context of unemployment insurance. The PRO Act would say that the test applies to determine who's protected by the right to unionize and bargain collectively, which I call labor law. It's called the ABC test because only those workers who are truly A, autonomous, that is free from any kind of employer control, B, who are in business or performing a business outside of the usual scope of the employer's business. Think the guy who comes to repair the HVAC system at a retail store is not engaged in the employer's business, but is in a totally separate line of business. And C, those who are customarily engaged in an independent business of their own, providing the same service, like an HVAC contractor, like a gardener, but not like a driver of an app-based car dispatch service like Uber. And so by adopting the ABC test for labor law, the definition of who is an exempt independent contractor would be significantly narrowed, and the scope of protections for employees would be significantly broadened. Another major thing the PRO Act would do is expand the right to protest about work-related matters. Here, what the statute would do is repeal many of the provisions of the Taft-Hartley Act of 1947, which radically restricted, at the time in the name of anti-communism, the kinds of protest that labor organizations can engage in. So specifically, what it would do, it would expand the right to strike by eliminating a provision or an interpretation of the law that the Supreme Court added, which allows employers to permanently replace striking employees. Permanent replacement of a striking employee is, as a practical matter, firing a striking employee in many circumstances. And so by taking away the right to permanently replace a striking worker, it would protect strikers from retaliation for striking. Second, the PRO Act would eliminate the ability of employers to lock out employees as a way of resolving negotiating disputes. Lockouts don't happen very often anymore, except in the context of professional sports, because long strikes are so unusual because of the employer's ability to permanently replace strikers. And so by eliminating permanent replacement and eliminating lockouts, we would likely see more strikes to resolve negotiating disputes. Third, under this provision of the PRO Act would eliminate the Taft-Hartley prohibition on secondary boycotts. Secondary boycotts is a complex concept, but to understand it, think of janitorial staff cleaning an office building who are protesting sexual harassment by their employer. Their employer is technically the owner of the small janitorial company that has a contract with the building maintenance company, that has a contract with the property management company. If the janitors stand on the sidewalk protesting sexual harassment and seek the support of, for example, employees of the tenants in this commercial office building, the National Labor Relations Board has held that they are engaged in a secondary boycott or a secondary strike because they're appealing to employees of an employer other than their own. The prohibition on secondary boycotts is wildly controversial in the labor movement, and by eliminating it, what we might see is more solidarity, whether it's a product boycott or a strike, among workers of different employers. The PRO Act would also eliminate the prohibition on striking or picketing to publicize that workers are seeking to organize or are seeking recognition from an employer. And so what the elimination of
Catherine, I apologize, but if you could, once again, we are nearly out of time, but and we have two more presenters. If you want to make a couple more points and sum it up, I thank you so much.
My pleasure. The rest of the provisions of the PRO Act would regulate the process of union elections by making them more two-sided. That is, giving employees greater rights to talk to each other. It would eliminate state right-to-work laws. That is, laws that prohibit employers and unions from agreeing to charge union represented workers a fee for the services that they provide. It would expand remedies for violations of protected labor laws by creating a civil cause of action. Don't have to go through the NLRB, civil penalties that aren't just a measure of back pay, and it would provide for mediation and ultimately arbitration for a negotiating dispute involving a newly certified union seeking to get a contract. And so what all this would mean is expanded labor rights would probably increase labor costs, that is, raise wages, and that might have a variety of financial impacts. But it will only do so, of course, in those industries where workers are interested in unionizing. Thank you very much.
Thank you so much, Catherine. And we're going to swing right into Megan, who is with the NAFA. Go ahead.
Thank you, and I'll do my best to be brief. Good afternoon. My name is Megan Gale. I'm here with Josh O'Gara. We're with the National Association of Insurance and Financial Advisors, also known as NAFA. NAFA is the preeminent membership association of financial and insurance professionals in the United States, representing a full spectrum of financial service practice specialties. Our members work with families and businesses and help them achieve financial security. We have 53 state and territorial chapters and 35 large metropolitan chapters. Our members are in every state and federal congressional district in the nation and advocate on behalf of producers and consumers at the state, interstate, and federal level. We're here not only to give a producer's perspective on the PRO Act, but also to talk about the importance of independent contractor status for independent broker-dealers and independent financial advisors. I'll start by saying that we agree with many of the points that Catherine highlighted today, and we strongly support better working conditions for marginalized and exploited gig economy workers. And while we recognize that the PRO Act is limited to the right to organize and that this bill is aimed at ensuring that marginalized workers have adequate benefits and bargaining rights through their employers, we feel it simply misses the mark for the insurance and financial services industry and the hundreds and thousands of independent broker-dealers and independent financial advisors who have built their livelihood on the independent contractor model. The PRO Act would amend the National Labor Relations Act by adding the language that expands the definition of independent contractor by adopting the ABC test that Catherine spoke about. It expands it to be employee. It is largely patterned after the California AB5 legislation, which we'll touch on again here shortly. Our primary concern is that the PRO Act uses the ABC test and that workers must meet all 3 criteria to be considered an independent contractor. And I'm sure you guys are all very familiar with these. So I will skip ahead. So the real crux of the problem here is Part B, that the work performed outside the usual course of hiring in the entity's business. For independent insurance producers, they often are, they sell their products within the, I'm sorry, the workers, since the insurance industry has long relied on quite successfully, I might add, on independent insurance agents to offer a vast variety of financial products as possible to the consumers, we likely fail Part B and trigger the employee classification. We are the dreaded unintended consequences that is all too common in an overly simplified model. If the ABC tests were confined to the PRO Act, then perhaps we wouldn't even be up here talking about it. But the ABC test is starting to gain traction, and if it were to become the standards, then there could be significant consequences down the road. We're already seeing it used in Senator Wyden's proposal for unemployment insurance. The Department of Labor is working to redefine independent contractor and is expected to use a version, and numerous states are exploring or have already adopted versions. This legislation opens the door for further policies that could negatively harm the way insurance carriers and producers best see fit to maintain their business structures. Producers could be caught in a quagmire of conflicting and uncertain employment status. I want to restate that we're not categorically opposed to this type of legislation, and we recognize and support the need of many industries for this type of protection. But even in an environment as progressively pro-labor as California, lawmakers recognized that insurance and financial services did not warrant inclusion in the California AB5. NAIFA National, our California chapters, and our industry partners worked very closely with legislators who amended languages to include a carve-out that you see here. This language is very important to note. As an industry, we're not looking to escape oversight or regulation, rather just to keep the oversight with the entities that currently perform these functions, like the state insurance and securities regulators or the SEC. There are a lot of reasons beyond those that we've touched on already that this rule is not a good fit for our industry, but the core is that the insurance and financial industry is a very different independent contractor model than the Uber, Lyft, or DoorDash gig style economy. Our agents do not work in short, fragmented, or episodic nature that you see in many of these industries. And the insurance and financial service industries is already one of the most regulated industries in the world. Almost every aspect of agent and producer consumer relationship is subject to scrutiny, oversight, and often approval. And additionally, and Josh will speak to this a little bit more, the entrepreneurial nature of the work is often what attracts producers to the business. Many are second career and intentionally leaving an employer-employee relationship. And that structure works for them and the industry, which has been able to operate on this model successfully for decades without significant complaint. Many independent insurance agents and independent financial advisors hold long-term contracts with more than 20 carriers to expand their product offerings. Employee status could reduce the number of products in their sales portfolio, which could ultimately mean less choice and higher prices for consumers. And it's really an important point here is that most importantly, our industry is not asking for this. NAIFA conducted a survey of over 1,000 of our members from across the country, representing a broad swath of practice types, ages, tenures in the industry. And the results were very clear. They're happy with their current employment classification and do not wish to change it, even for the right to organize. Legislation should not force a relationship between carriers and producers that they do not want. But you don't have to take it from me. So I would like to introduce Josh. Josh is the owner of O'Gara Financial Group and the president of our Massachusetts NAIFA chapter, and is here to share his experience with you.
Go ahead, Josh.
Thank you, Megan, and thank you to the council for inviting us to testify this afternoon on the PRO Act. As Megan mentioned, want to emphasize the fact that we are not in opposition to the bill. We are not anti-union. I actually, as Megan referenced, many people in the insurance business are career changers. There are few individuals who grow up saying, I want to be an insurance agent. Part of my path into the insurance industry, I actually spent some time working at UPS. I'm a proud card holder of the Teamsters Union from my time, and my wallet would actually make George Costanza proud. I still have that card sitting in my wallet. So I have a lot of experience with both that employer-employee relationship, and the reason why I started my own practice was for that independence that I was looking for. As Megan had alluded to, I have contracts with multiple different insurance companies, and ultimately, NAIFA has about 400 members here in the state of Massachusetts, 20,000 members across the country. We're all small business owners. It's a 100% volunteer organization. But really, this boils down to a consumer choice issue. If we get wrapped up into the PRO Act to the point where we now become W-2 employees and there's an employer-employee relationship with each carrier that we have contracts with, we just wouldn't be able to offer the same sort of choice to the clients that we work with. So that's really the most important issue here, regardless of how I feel about being an independent contractor and having the independence to run the practice the way I feel fit. It's really important to maintain consumer choice. And insurance ownership right now is at probably some of the lowest levels it's ever been. There aren't enough people in our business right now. We've dealt with a lot of regulatory changes over the last 5 to 10 years that have, completely changed the way my business looks. I got into this business in 2006, and my practice is completely different now than when I started. I actually started as an agent with Northwestern Mutual, again, in that employee-employer relationship. Not to say that there's anything wrong with that. The choice is still out there for people that want to have that option. What we're asking for is an exemption specifically for our industry because I think it's warranted. It was an exemption that was provided in the California regulation, and we would like the same consideration for the PRO Act at the federal level as well. So thank you again for your time this afternoon, and I guess I will turn it over for questions.
Since we don't have any time for questions, Josh, you're off the hook on that one, but I do understand exactly where you're coming from. I know there's a lot of tremendous amount of regulation in your industry. So with that, thank you. And we've got a couple of minutes for Paul from the RAA is out there somewhere. Paul? Okay, go ahead.
Chairman, members, Paul Martin, Reinsurance Association of America. Members, you will recall in our discussions in Charleston regarding the Division Act, I mentioned that Senator Rapert was running the IBT Act, that is a model act of NCOIL. With our work with him and the department in Arkansas, we have made some minor improvements to the bill. We would like to have a discussion with the committee in the next few months so that when we're in Scottsdale, we can reopen the bill and hopefully make some improvements to it. And 26 seconds, Will, if you are counting.
All right. Wonderful, Paul. Thank you.
Thank you, sir.
All right, committee, with that, I need a motion to approve the minutes of the last meeting. Motion from Paul. Is there a second? Over here, second. All in favor of the motion, say aye.
Aye.
Opposed, no. Motion carried. Okay, committee, we are going to take just a 2-minute break before the next group begins. So with that, motion to adjourn.
So moved.
Is there a second? Second. All in favor of the motion, say aye. Opposed, no. Motion carried. Meeting adjourned.
But we hope and expect it will be very informative. So we're going to go ahead and get started and try to keep to our time frame. So the first thing is I'd like to welcome everybody on Zoom. Could any legislators on Zoom please identify yourself?
Ken Cooley in California, Madam Chair.
Ronnie Cromer, South Carolina.
Representative Jim Gooch from Kentucky.
Okay, anyone else? Other legislators? Okay, very good.
Kaiser from North Dakota.
Great, thank you. That's it. Okay. The second item I'd like to do is have somebody make a motion to waive the quorum for this meeting.
So moved.
Can I have
Seconded.
a second? Thank you. All those in favor, please signify by saying aye.
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 Any opposed? Okay, we'll move forward. Our first order of business is to approve the April 16th, 2021 committee minutes from that are found in your materials. Can I have a motion for approval?
So
Thank you.
moved.
And a second? Great. All those in favor signify by saying aye.
Aye.
Any opposed? Minutes are approved. Thank you. So we move on to our discussion of Interstate Insurance Regulation Commission, and our first speaker is Mary Jo Hudson. Ms. Hudson, would you like to begin?
You are muted, Ms. Hudson.
Thank you so much. Thank you, Madam Chair, and good afternoon, everyone. My apologies for the mute button. I am terrific to be here. I'm Mary Jo Hudson from the law firm of Squire Patton Boggs. I'm based in Columbus, Ohio. I'm a former NCOIL veteran, as a former Ohio Director of Insurance from 2007 to 2011, and served as an officer of the Interstate Compact for all 4 of those years, and served with your Executive Director, Mr. Considine, as well. So great to be here. I want to go quickly through I have a little deck. I'd just like to give you a little background on compacts. And so, Will, if you could advance the slide. The first is we're talking about the Interstate Insurance Compact. I know you hear a lot about it. Just to give you some background, what is a compact? You all deal with compacts, I'm sure, in your roles, but it is a contract among the states. Very important governance tool used by the states to get work done without relying on the federal government, and the states do it themselves. There is a clause in the Constitution regarding compacts, but you don't have to have federal consent to have a compact. If there is federal consent for that compact, whether it's expressed through a specific bill or implied, which means Congress has recognized the compact but didn't do anything to change it, those terms in the compact can preempt conflicting state constitutional terms. So if you go to the next slide, Will. So with that in mind, we go to our compact, the Insurance Compact Commission. Now the ICC has been around, this year is its 15th active year with 46 states involved. And I have to say, working as an insurance commissioner, we were just starting with about 26 states when I started back in 2007, and it's great to see this success. That success is due in a large part to the efforts of NCOIL, who helped get this compact up and running all that time. It's a great legacy. Upon that formation, the compact, the ICC became what's referred to as a joint public agency of all those member states. If you think about it, it's a separate body. It is not part of the NEIC. It is staffed and supported separately from the NEIC. There is some support. There's office sharing, et cetera, but it is not part of the NEIC. And each state commissioner represents that compact as the state representative to that compact. And then the staff at the ICC, is Karen Shutter's on the line, They are the staff of that compact. And so the compact, as you may know, regulates the product terms for life insurance, annuities, disability, and long-term care insurance products that are sold in the states there. So if you want to go to the next slide, please. The life insurance companies don't have to file the compact. Many choose to, as Karen, I'm sure, has reported to you before, and we'll talk about. It's incredibly successful, and many life insurance companies use it regularly. It really improves speed to market and helps have uniformity in their products through the country. That helps streamline compliance and helps make sure that sales are streamlined as well. So very important. So I'm here today to talk about this. You've probably heard there was a court case that came out in last year, well, around the end of 2019, Amica v. Works. It was a decision out of the Colorado Supreme Court, and that decision, it challenged some of the terms of the compact. My firm was retained by the Insurance Compact Commission to do a review of the compact's governance and that Amica v. Works decision. So we'll talk about that for a second. If you could go to the next slide, Will, thank you. In that Amica v. Works decision, the Colorado Supreme Court ruled that the Colorado Constitution preempted the interstate compact's uniform standards on life insurance based on the assumption that the interstate compact does not have any congressional consent. The issue there was in Colorado, in the Colorado Insurance Code, they have a 1-year suicide exclusion. Only one other state, Missouri, has that as well. But then all other states are 2 years, and the compact standard was 2 years. Someone brought an action or brought a claim and said they should get paid on a benefit for 1 year, and the insurance company challenged it and said no, it should be per the uniform standards. The issue was, it was handled, in our opinion, the court did not handle this situation properly. It was in a federal court, and that's kind of beside the point for our purposes today. But the bottom line is the Colorado Supreme Court issued a decision that said our Colorado statute controls rather than the interstate compact's uniform standards. That is quite contrary to the terms of the compact that Colorado adopted, as well as all of the other member states. Part of our analysis found that the interstate compact has received congressional consent through what's called the doctrine of implied consent. That when Congress approved the District of Columbia becoming a member way back in 2006, Congress consented to the compact, and that consent is sufficient to support a congressional consent. The court in the Amica v. Works court, the Colorado Supreme Court, did not discuss that, did not look into it. Nobody really briefed congressional consent, so they sort of went off on their own side analysis to make their findings. But this implied congressional consent is a very strong argument that up to this point, the interstate compact and the states have not really had to pursue. So if you go to the next slide, Will, please. So what's next? And this is this Amica decision, in our opinion, as we did this analysis for the compact, should have a narrow impact so long as the states and the compact going forward stand up for itself in effect and say, what, educating regulators, the states and the public about the body of law that supports the compact, about the importance of maintaining compacts in the way that the legislatures adopt them, and acknowledging that implied congressional consent, so that that other litigants can't go out and try to use this, I think, poorly decided decision from the Colorado Supreme Court to erode certainty and uniformity that comes right now from the Interstate Compact's wildly successful program. So we made several recommendations to the compact to try to help shore this up. And it really, there's no silver bullet to stop challenges in the future. But what can happen is it's about providing information that could be cited in other court cases to educate state regulators and legislators so that you all know, and so that you talk about it as if those uniform standards do apply rather than one-off state requirements or regulator requirements. And also we did recommend that the compact begin to add in its uniform standards that if there is litigation like the Colorado litigation, that the compact is required to be brought in as a party so they can intervene. So that's a very quick update. I know you're short on time, and Karen Shutter from the compact is also on the line. I'm here. I'd be happy to answer any questions. And in the deck that's in your materials, my contact information is there too if I could be a resource. Thank you.
Thank you very much. Are there any questions at this time? Anybody online? Okay. Thank you very much, Ms. Hudson. That was helpful. We're going to move on to our next speaker, Karen Shutter. Are you here?
Yes.
There you are.
Can you see me?
Yes.
Can you hear me? Okay. Good afternoon. Thank you for letting me join you today to give you an update on the compact. I can hear a little bit of a background noise. Is that my fault? Hopefully not. I want to thank Mary Jo Hudson. She was retained as a consultant to do our governance review. And a lot of the recommendations that have come out of their report are very important. And our regulators, I'm here on behalf of Rhode Island Superintendent Beth Dwyer, who's our chair, Vice Chair, Wisconsin Commissioner Mark Afable, and West Virginia Commissioner and our Treasurer, James Dodrell, as well as all the other members, the 46 compacting states. I know you'll have Director Cameron, Commissioner Mulready, and Commissioner Cheney at your meeting. They are all members of the commission. Their legislatures have enacted the compact. And we have worked very closely with NCOIL. I know we updated you several times. We generally have a standing update on your agenda, as well as we've done even more detailed education for those legislators that are new to the compact and want to understand why the states came together to collaborate and agree upon uniform standards that really are developed through a comprehensive process. We involve legislators. We have a legislative committee, and we adopt uniform standards that will apply to products that really cross state borders. You could have a consumer who buys a product in another state, moves into your state. So it makes sense that these are standard across the states. They also compete on a federal basis with securities and banking products. And there has been a long call by the industry, and it was a very serious threat for probably 15 years. We don't hear as much about it, of federal preemption in these areas. And a lot of the reason you don't hear about it is because regulators and legislators and states are working together through the compact to make product approval more seamless through uniformity. So I would like to recognize those state legislators who have been very active and engaged in the commission's activity. The chair of this committee, Assemblywoman Maggie Carlton, is on our legislative committee, as well as your president, Matt Lehman, and your secretary, Joe Fisher. You also probably know Rhode Island Representative Brian Patrick Kennedy, Utah Representative Jim Dunnigan, Georgia Representative Matt Dollar, and Illinois Senator Laura Fine. They are all members of our legislative committee today and are very active. We have regular calls with them, as well as they attend our meetings, and you will see they sit with the commission in all of our deliberations. Senator Hackett, Senator Rapert, Senator Holman have all served on the legislative committee. Mary Jo gave you a really concise, comprehensive overview of really what was the first case that got to an opinion, the Colorado Supreme Court. And it had a lot of twists and turns, with a lower court actually ruling that the compact was constitutional. States, legislators understood what they were doing. It could enter an agreement. But with this Colorado Supreme Court, we do appreciate the recommendations that came out from Squire Patton Boggs, and we are looking at them. Implied congressional consent, obviously that has meaning in terms of the dialogue. And what our regulators, what the compacting states are doing, we have a governance committee of our officers along with Colorado and Texas. They are looking at responding to the recommendations from Squire Patton Boggs, putting together a plan of action, and working with the members of NCOIL, working with other organizations such as NCSL, National Attorney General's Association, Council of State Governments, who has a National Center of Interstate Compacts. So it's going to really be akin to what all the stakeholders did back in the early 2000s when the compact was first developed, really going and raising the awareness again of what the compact was, what the achievements have been. And really the achievements have been that right now, the industry is using the compact. So most products that have been approved over the last 10 years are likely compact approved products, life, annuities, long-term care, for 46 compacting states. Soon to be 47. I'm happy to let you know that the legislature of Delaware enacted the compact at the end of June. So it is waiting Governor Carney's signature. So we'll be welcoming them. So for 47 states, you can have a uniform product that comes through the compact. We have actuaries and form reviewers that look at that compact, that look at that product under very detailed standards. Everything is transparent to your regulators. Your regulators are the one that actually are involved in the standards and what we're doing. So I was asked to bring to your attention actually an issue that the commission has been dealing with for this past year. And it is a little bit of an outgrowth of that Colorado Supreme Court case where it made our regulators really pause, I guess I should say. And let me tell you what the issue is. At the last year, through working with the industry, the regulators opened up a model law. It was a standard individual deferred non-variable annuity law. I'm sorry, individual deferred annuity laws, non-forfeiture. And what they did is they amended a minimum non-forfeiture rate because of the exceptionally low interest rate environment, not just historically over the last several years, but because of the pandemic and how it really tumbled. So they amended through this model law at the NEIC, they amended the minimum non-forfeiture law. It was 1% and it went down to 0.15%. A lot of good reasons for it. Again, so there can be product offerings in these areas. But what we did is, in our uniform standards, that requirement is actually incorporated by reference. I understand that has a meaning, probably, and it does have a meaning at NCOIL. But what happens in our standards, we incorporated a lot of the technical models of the NEIC. And because this is a substantive and it is on its face, so there's a lot of good consumer benefits for this, was lowering something, we decided to pause and not incorporate that immediately into the standards. We wanted to wait because that standard non-forfeiture law is actually a statute in the states. So we wanted to see how states were going to enact that change. And so far, I know not all legislative sessions there are some that are still going on, but most have winded down. Of the 46 compacting states, 10 of them have enacted this change. So that means the majority of them have not yet enacted it. So we paused bringing that standard into, or incorporating that standard automatically, or that amendment automatically into our standards. And what we did is we indicated in our standards that a company must follow the minimum non-forfeiture rate in state law. So this does take a step back from uniformity and the benefit that everyone did bargain for. But again, because it was something that was incorporated by reference, we wanted to, and this was probably the first time it happened in the 10 years of the compact, we did draft an emergency rule, put an emergency rule in place, and we took a pause. And what we have said is that provision is following state law. And I think we're probably relook at that in a couple of years as more and more states embrace this change, and then we'll program back in a set standard. But there are some examples in our uniform standards where we actually do go back to state law, maybe because it's a public policy that maybe one half of the states are on one side, the other are another, or it really is just a public policy that's outside of the contract, but companies want to program that into their policy. So we do have an examples of what we're doing. And again, this looked a little bit like we were stepping away from uniformity, but again, many of our members were very deferential to our legislators, wanting to make sure that this change that was made at the NEIC in a standard non-forfeiture model law was one that states would embrace at the state level before it then made its way back into the standards. I will also say that we are likely going to be looking at some of our standards, one of the main ones being the suicide exclusion. We find that our uniform standards have been widely accepted. They're based a lot on the NEIC models or a lot of what NCOIL does and what is already adopted in the states. There are some states that might have some, I like to call it a one-off requirement, and some of it might be meaningful. So in Colorado, what happened is they have a 1-year suicide statute. And as Mary Jo said, we only have 2 compacting states that have that. But that's a meaningful conflict. When you look at, we have a 2-year and they have a 1-year. So we will be looking at those type of provisions and seeing if we can minimize that conflict so that we don't, so that first of all, whether it's the beneficiaries or the policyholders don't feel like they have to go to litigation. So again, I did want to end with the good news about Delaware, and I'm happy to answer any questions.
Thank you. Thank you very much. Anyone have any questions for Ms. Shutter? Thank you for the update. I did want to note Assemblywoman Carlton, who is on your board, I am not her.
No, I appreciate
I
that,
am the vice
Representative
chair.
Thomas.
So I just wanted to make sure she couldn't be with us this afternoon, but we appreciate her work and her work with you. Thank you very much. We're going to move on to our next item on our agenda, which is federal retirement initiatives. And we have Bradford Campbell with us, the speaker.
Yes, ma'am.
It's good to see you in person.
I was going to say, this is the first time I've been able to be in person anywhere other than home, so I'm very grateful for the opportunity. My name is Bradford Campbell. Madam Chair, thank you for having me here and the other members of the committee. My name is Bradford Campbell. I'm a partner with the law firm of Faegre, Drinker, Biddle, and Reith. And I previously, from 2006 to 2009, served as the Assistant Secretary of Labor for Employee Benefits, the head of the Employee Benefit Security Administration, which administers ERISA, the fiduciary and reporting provisions governing retirement and other private sector employee benefit plans. And so in my work there, I spend a lot of time working with clients who are dealing with the overlap and the issues created by federal law and regulation intersecting with the work that you all do in regulating state insurance products. And we wanted to start out, I was going to address 3 different topics today that are relevant in what both the Congress and the executive branch are doing currently in an area that will affect you all. One is dealing with the Secure Act, the second edition of the Secure Act, and the annuity provisions that are in it. And 2 others deal with regulations from the Department of Labor that are affecting the conduct standards and some other annuity-related issues for participants and insurance producers and others related to those plans. So to start with the Secure Act, as you all probably recall, we're talking about Secure Act 2.0 because we've already done the first version about 2 years ago. And what we had seen on a bipartisan basis in Congress was concern that there is not enough take-up of guaranteed income products of various sorts in retirement plans governed by ERISA, and that there needs to be an encouragement to have those products be made more available to provide certain guarantees to participants, particularly in defined contribution plans like 401ks. And so out of that, in the first Secure Act, there were 3 provisions, and I should say there are many reasons for that, and that's partly what you'll see as you look at what Congress is doing with the Secure Act. In the first version, they provided greater rules for portability so that a 401k participant who found the 401k plan stopped offering an annuity product from one provider and then switched to another would be able to, for example, roll that annuity they had purchased into an IRA and be able to have that portability and not be at a disadvantage because the plan had changed the investment options. There was also established in the original Secure Act a safe harbor for the selection process for the annuity provider, so that if the fiduciaries of the 401k plan, the persons charged with making those decisions on behalf of the plan, if they follow the list of elements under the federal statute, would have a reduced civil liability in the event that annuity provider was later unable to make payments. The idea there being to encourage, to reduce the concern about potential liability as a barrier to adopting those. The third provision was to require that on an annual basis, 401k plans and other similar defined contribution plans would provide to participants a projection of the retirement income that could be provided by something like an annuity based on the amount they've accumulated in their 401k plans. That last provision passed, and it is something I'm going to talk about in a moment, because with passing that provision in law, it then came to the Labor Department to implement it through regulation. So we'll address where that implementation process is next. But because the Secure Act was so successful and bipartisan, it literally, I think, had only 3 votes against it in the entire Congress, which is quite a feat for a substantive piece of legislation. They decided to take another run at making some necessary changes to retirement plans. And so the Secure Act 2.0, which is a bill that has been passed by voice vote by the House Ways and Means Committee earlier this year, is a package of, say, 20 or 25 different elements, different provisions. And there's 3 of them that passed that are related to annuity providers and trying to make annuities more available. These are a little more technical, but they address some of the tax code issues that have also contributed to limited availability of annuities in retirement plans. The first and probably most significant is facilitating qualifying longevity annuity contracts. Because of the required minimum distribution rules under the tax code, which mean that once you achieve a certain age, you are required to start taking distributions from your 401k plan. The way those rules were originally structured, no more than 25% of the assets in a plan could be devoted to a QLAC. And that was presumably to prevent over benefiting from the tax benefits. Congress, certainly at least in the House, has decided that that actually is limiting the availability of what are useful products for retirees. And so they've removed that would remove in the Secure Act 2.0, that 25% limit. So that would allow effectively an amounts up over 500,000 to be put into a QLAC. So that would facilitate that. Another change, of course, in general, is increasing the required minimum distribution commencement age from 72 to 75, phased in over 10 years, which would provide more time and less mandatory drawdown on some of those assets, which indirectly facilitates annuities. They would also permit, because exchange-traded funds didn't exist when these provisions were written in the code, they would also permit now a class of exchange-traded funds to be used in annuities by changing the way the taxation of those is. In other words, there wouldn't be internal capital gains. These would now be eligible to be taxed as ordinary income when distributed, just as other types of retirement savings in that space are. And lastly, they were going to change the actuarial rules for calculating retired minimum distributions that have made it difficult for certain, what are otherwise common and popular annuity features, like return of premiums, certain return of premiums on death, and being able to provide non-level annuity payments. And so by facilitating those various changes, the Secure Act would make annuities somewhat more attractive and somewhat more useful in this context. As I said, that bill passed the House Ways and Means Committee by voice vote. There is similar legislation in the Senate offered by Senators Portman of Maryland and Cardin of Ohio, who have previously worked together on significant retirement reforms. Chairman Wyden of the Finance Committee also has some variations. It's not clear yet when the Senate is going to act on this legislation. What is pretty clear is that there's a lot of support. And when you speak to folks on Capitol Hill about it, they all think the Secure Act or some variation of that incorporating the Senate's views will pass. What no one can commit to is when it will pass. So I think we're all pretty optimistic that some variation of these proposals will come through. Whether it happens later this year in sort of the end of the year must-pass legislation that we always seem to find about, funding or defunding the government, approving an increase in the debt limit, those sorts of bills. Whether it's incorporated there or whether it comes earlier next year, we'll see. But the prospects for the legislation look good. As I mentioned before, the Labor Department is charged with implementing the lifetime income disclosure rule, and the reason I think that's going to be pretty significant is it will give participants sort of real estimations about how well they're doing in retirement savings and the value potentially of having an annuity form of payout. The reality is, if you tell me I have $350,000 in my 401k, I say, that's great, I'm doing really well, but I have no idea what that actually means for money I'll need in my retirement. But if you say, well, based on the $350,000, you have $600 a month or whatever the right number is in retirement income, that I can process immediately. And so I think it's a very useful, simple way to try to explain to participants the value of their retirement savings. What is not simple about it is how you calculate that number. What's the methodology that you use? And that's what the Labor Department was tasked with doing by Congress. The Trump administration issued an interim final regulation last September. Interim final is a regulation where if they don't change it, it will apply as written, but they are taking comments or took comments on it and would consider changing it. So unless the Biden administration acts, the Trump rule will go into effect this September and likely will apply to most plans in the first part of next year. Just recently, a few weeks ago, the Biden administration announced that it does intend to change that rule and is scheduled at least to propose a new final rule for that disclosure requirement and the methodology, scheduled to do so in July. I have to say they are unlikely to make that deadline, given that they have not yet sent the rule to the White House for review. We know publicly when rules go for review. We don't know what's in them until they come out, but it's not yet gone for review, and that review can take up to 90 days. So it seems unlikely they're going to meet their July deadline, and that in turn raises a question of will they extend the September deadline? We'll have to wait and see. But what's at issue there is some questions about what's the right methodology and will these be helpful or confusing. In particular, should you take the current account balance? If I'm a worker who's 25 with $5,000, are you going to pretend that I'm 67 and give me a disclosure that says I get $18 a month in retirement income? Or are you going to project that 5,000 balance forward to retirement age, assuming certain contributions and growth, and then calculate the annuity number? Those are the kinds of issues the Biden administration is presumably going to address. The Trump administration chose the simplistic number of using what do you have in your account today, and we'll pretend you're retiring today. Here's the number. A lot of folks, including Chairman Neal of the Ways and Means Committee, congressman here from Massachusetts, suggested that they should use the more complex but potentially more useful calculation. So we will see when they propose the rule and what's in it. Due to the nature of an interim final rule, we won't see what's in the final rule until it's published because comments were already taken on the other proposal. So it's sort of an unusual wrinkle in the administrative process. The last issue, and I apologize for taking so much time, the last issue deals with the Department of Labor's fiduciary regulation. The issue there is when is someone who's giving advice to a participant in a retirement plan subject not only to their normal conduct, in the case of an insurance producer, your rules and regulations about, for example, recommending an annuity, and when are they also subject to the federal government's ERISA fiduciary standard? And what the Trump administration did and the Biden administration agreed and ratified this February is that they have expanded the interpretation of the existing rule to mean that most rollover recommendations would now be subject to ERISA's fiduciary duty. So the difference is if it's truly a one-time recommendation, that can still be viewed as a sales event. That's not ERISA fiduciary advice. But if I'm recommending an annuity where I'm intending to give you additional recommendations as we go along in the relationship, then it would be subject to ERISA's fiduciary advice. The reality is that ERISA and the concept of commissions, standard forms of insurance compensation, don't play well together. Under ERISA, a commission is a prohibited transaction. It's not a permitted form of payment unless there's a special rule that says it is. And so there are new special rules that have also gone into effect in February that were intended by the department to let these two issues coexist, to let insurance producers, broker-dealers, registered investment advisors, kind of the full range of different financial professionals be able to make these recommendations and still get paid, even if it's a commission form, subject to additional conditions. There has been quite a bit of debate within particularly the insurance industry that says that the new exemption, the special rules, which is called Prohibited Transaction Exemption 2020-02, there's been a lot of concern that it doesn't properly take into account the realities of independent distribution, that it assumes a level of control between the financial institution and the financial professional that works in a security setting but doesn't work in an independent distribution setting where the carrier doesn't have control over the independent producer, which is by design as a consumer protection at the state level. So there's a disconnect between where the Labor Department is going and where state insurance regulation is. And DOL has announced that those rules that apply in February, there's an existing exemption for insurance that can be used. But by this December, DOL is going to propose a new fiduciary rule that will change this existing interpretation that just came out and may change exemptions as well. So to sum that up, what we have is a new DOL interpretation that's capturing more insurance producers as ERISA fiduciaries, new exemptions that may or may not adequately cover the needs of those producers in making those recommendations, and on the horizon, an entirely new regulation and a new start to the entire process. So if you enjoyed 2016, when the Obama administration changed the fiduciary rule, and that was eventually vacated by the federal courts in 2018, you'll enjoy the next 2 years because we're going to have many of those same debates again. Thank you for your time.
Thank you very much. And I'll take questions. I'm going to ask the first one. Is there within the requirements an explanation of how they're doing this that's going to go out for these people that live in our states that explains this is our projection, no matter which way they do it? To me, it's more important that they explain what they're doing and how they calculated it for people as much as the actual number.
The exact details would depend on how they're going to change it in the final rule. We just this June learned they actually were going to change it, so that was an open question. In terms of what it says currently, there would be a disclosure that explains generally how it was calculated. How useful that would be to the average participant to read the fine print is an open question. But the benefit of the path the Trump administration chose is that it's simple to calculate and doesn't have a lot of variables. The disadvantage, and this is my personal opinion, is that it doesn't help me if I'm a younger worker with a small balance to get a notional projection based on where I am today when that's not where I'll be when I retire. In some ways, this is modeled on the federal government's thrift savings plan, the government 401k, which provides an annual annuity projection. And having been a participant in that as a former federal employee, I found that projection to be of no help to me whatsoever. When I was 30, I wasn't near retirement. When I was 40, I wasn't near retirement. It appears that when I'm 50, I won't be near retirement. So, telling me what that annuity is going to be based on the balance today, when it has changed radically over that period, I think has very limited utility. I think it needs to be projected forward using more assumptions. But as you point out, that would take also a lot more explanation.
Any other questions on any of the topics? Thank you. I'm sure we'll see you again since all of this is pending. Thank you very much.
Thank you very much.
And our final speaker this afternoon to talk about life and health insurance guarantee associations. Peter Gallianos, I hope I said that correctly. Peter, are you there?
Madam Chair, I am with you on Zoom. Can you hear me?
Yes, we can. Thank you. Please begin.
Thank you. I have a slide deck that I'm going to be referring to, but I know that you are pressed for time today, and I'm probably the only person standing between you and the Ovaltine line. So I'm going to try to make this just hit high points. I was asked to give a report today, basically on at a high level on the nature, operations, concerns, and prospects for the life and health insurance guarantee system, to talk specifically about the effects of the pandemic on the guarantee system, and to address any special issues that might exist between the insurance guarantee system on the one hand and captive insurers on the other. To begin, if I could just on the slide deck, I'm on slide deck 2 right now, or on slide 2. I just wanted to make the point that at a very high level, the system of providing a financial safety net for insurance consumers in the rare cases when a life or health insurance company fails, that's been established by the state legislatures, working with the regulators, working with the industry and consumer representatives, has been refined repeatedly over the period of the last 4 decades. And I think we're in a position right now where this system has proven again and again that it does a good job of protecting consumers. And I think that's in large part because of the hard work that NCOIL members and other important leaders and stakeholders have taken. So if current trends continue and absent extraordinarily special or unexpected problems, I think we can look forward to more decades of success in providing an effective safety net for insurance consumers. Now, turning for a second to slide 3, I was asked to report on the effect of the COVID pandemic, and I'm very happy to be able to report to the committee that although operationally behind the scenes, we had to begin doing a lot of things differently to make sure that we could continue to provide through our state member guarantee associations the same types and levels of protection that we have historically when we've been called upon to perform. The pandemic itself really had, first of all, it resulted in no material increases in the number of insolvencies of life and health insurers. The industry stood up very well. Second, the pandemic did not result in increased costs of the guarantee associations providing protections to policyholders. And finally, because I think we did a lot of scrambling, increased reliance on technology, and did a lot of the other things that you folks and others have had to do to be able to continue doing business over the course of the last 16 months. There really was no net effect, at least from a consumer perspective, of the pandemic on guarantee system operations, which is a good thing. So if we could go to slide 4, I'd like to talk about the other specific question that I've been asked, and then I'll go to some more general points. Specifically, I was asked if I could give any available insights on how captive insurers and the guarantee system relate to each other. And I think the short answer is that guarantee associations protect consumers who have policies with member insurance companies that fail. Now, first of all, there aren't a lot of them that fail. But second, by and large, captive insurers are not guarantee association member companies. So it really has never been the intent, and it is not the outcome, that when a captive fails, policyholders of the captive are protected by the guarantee associations. The interest in captives, because a lot of captives, for example, are reinsurers, and they have an indirect sort of financial implication for companies that would be protected by the guarantee system. But so far, in our experience, in the 100 or so multi-state insolvencies where NOLGA members have been involved, we really have not had material challenges that have been posed by any captive insurer or reinsurer being part of the picture. So from our standpoint, it's really been an issue that's been pretty remote to our concerns and operations. So that said, I'd like to talk a little bit, and again, I'm just going to try to hop through this at a high level about the current state of the guarantee system, kind of how we got to where we are, what we're doing, how we're doing it, what we're concerned about. Looking at slide 6, just some background points here. I think you know that we have basically 2 separate systems reflected by guarantee associations of 2 different types in every state. There is in every state a life and health guarantee association. In every state, there's a property casualty guarantee association. And in each system, there is a national organization that has been formed by the individual guarantee associations to provide support and services for those individual GAs. In the case of the life and health guarantee system, that support mechanism is NOLGA, the entity for which I work. But the guarantee associations and the guarantee systems basically developed in the late 60s and early 70s. We work closely with receivers and insurance regulators to make sure that when a company fails, consumers get protected. And that's our focus, protecting consumers, not bailing out companies that for whatever reason have not been able to make it. Next slide, number 7. The elements of the guarantee system basically are in the life and health side anyway. You'll be hearing tomorrow, or a different committee will be hearing tomorrow from our counterparts on the P&C side. We have guarantee associations in all 50 states, in the District of Columbia, and in Puerto Rico. Each one of them is a separate legal entity established by a state law that your legislatures have passed. Now, those laws are basically drawn from, at least on the life and health side, an NAIC model. There are some differences state to state, tailoring to specific state preferences, but broadly speaking, there's a great deal of similarity across the country. And as I say, NOLGA serves our member guarantee associations and was created by them to support and deliver efficiencies and cost-effective solutions that benefit consumers and keep the cost of the system down. On the next slide, the way we go about this basically is when the GA's obligations under their statutes are triggered, usually by a liquidation of an insolvent company, the guarantee associations continue the coverage. That is to say, they honor the commitments of the failed company so that we're not taking somebody who's 20 years into a life policy or an annuity and throwing them back out onto the marketplace where they have to replace that. In that regard, we're a little different than the property casualty guarantee system, where for most lines of business, coverage is canceled and the policyholders are able to go back out and get replacement coverage on business that typically is repriced and rewritten on an annual basis anyway. It doesn't work that way with life contracts, with annuity contracts, and some kinds of health contracts. So if you're going to honor the commitment, you have to continue the contract. Our preferred way of doing that is by supporting a transfer of the business that's in force when a company fails to another healthy company. And that's done basically by giving the healthy company that takes on the liabilities assets that are usually made up largely by assets in the estate of the failed company, plus topping up payments that cover a deficiency that are provided through the guarantee associations. The GAs cover people who are residents of their states. It's residency based. And each state determines the level of protection that's provided. But the levels of protection are generally pretty consistent across the country on the life and health side. And I've given to Will a separate document that you may want to look at that illustrates that graphically. So moving to the next slide, I think I've already talked about this. You know, when there's usually a question or a concern, how does the system get paid for? Well, the largest chunk of funding for the performance of the guarantee system is from assets that remain in the estate of the failed company. They failed, which means basically that their liabilities exceed their assets, but they usually have a significant amount of assets that provide, depending on the type of company, 50 cents on the dollar, 70 cents on the dollar, 90 cents on the dollar. And essentially, the guarantee associations provide most of the rest that's necessary to protect consumers up to guarantee association coverage levels. Guarantee associations also benefit from receiving premiums on policies that pay premiums. There are some statutory deposits that legislatures provide for that also support the activities of the guarantee system. But the bulk of what we think of in terms of guarantee association funding comes from assessments that are made to member companies. And in some cases, those assessments are subject to tax offsets over a period of time, reducing the amount of otherwise due and owing premium taxes. I just want to dwell for a second on slide 10. For people who don't know a lot about the guarantee system and how it is performed historically, this slide talks about some of the facts that not everybody knows. First, there are very few cases historically of life and health insurers of any significant size that have failed. And I'm going to point to the 2008 financial crisis and the pandemic, worst of the pandemic last year. There were no life or health companies of major significance that failed because of either the 2008 crisis or the pandemic. Second, unlike banks, insurance companies are really not subject to run on the bank behavior. And that's because, if you look at the third point, the liabilities usually come due over a very, very long period of time, which means that our cash needs are a lot lower than the FDIC, for example, needs to fund when a bank fails. We've already talked about the role of the assets of the insolvent insurer. We do have operational resources to keep the benefits going to policyholders. And it's historically, the performance of the system, I think, has been really solid over the years. I don't think there's ever been a case where a guarantee association has failed to pay a penny of what your statutes call for them to pay when a consumer's company fails. I've got a couple of slides here. Slide 12 shows the number of cases that we've had to respond to over the course of the last 30 years or so. As you see, this shows the number of multi-state cases is really pretty small on an annual basis, and certainly has been over the course of the last 20 years. Slide 13 answers the question that people often ask: do you have the financial capacity within the guarantee system to respond to failures by companies? And this chart really captures the answer to that question. At the bottom of the chart, you'll see a little bit of a green that appears, and the green reflects the amount of money the guarantee associations have had to spend to protect consumers on a year-by-year basis. The blue reflects the amount of funding capacity that we have. And although this chart is simplified, and if you drill down, there are a lot of different ways to talk about this, I think it gives you a sense that the total capacity of the guarantee system nationally historically has always been much greater than the amount it's cost us to run the system. So moving to the next slide, I list a few of the recent cases that we've been confronted by. We actually have to spend money protecting consumers when there's a liquidation. And there have been a few cases in recent years. I'll talk in more detail in a minute about the types of cases that we've seen and that we continue to watch. Rehabilitation often leads to a liquidation, so we also watch rehabilitations, but guarantee associations typically do not pay money out in a rehabilitation. So I'm going to go now to slide 16, which is where we're talking about challenges to the guarantee system as we move forward. And I would say that our biggest challenge over the last 10 years, and likely our biggest challenge over the next 10 years, has been in the area of long-term care insurance. Some of the reasons, particularly for the problems with older long-term care insurance, are spelled out on the top half of this slide. And some of the challenges to try to rehabilitate these blocks are spelled out on the bottom. We literally could spend 5 hours talking about long-term care insurance, but we have seen some cases recently. We're likely to see more, and it is an area of concern that, you know, I'd be happy to come back and help discuss with you at any time moving forward. The next slide, slide 17, mentions a few of the recent long-term care cases we've seen. The biggest one that's hit liquidation so far is Penn Treaty in Pennsylvania. There's a much smaller company called Senior American that has been in liquidation. There is a case in Pennsylvania right now called SHIP that is in rehabilitation and may or may not at some point end up in liquidation. There's another rehabilitation in Wisconsin that's largely long-term care company called Time Insurance Company. And I think we're going to avoid having a liquidation in that particular case, although, you know, I'm just talking about, you know, what's been public about that case. And the signs seem to be pretty good. There have also been some work streams at the NAIC, and my guess is at NCOIL too, that have been focusing on LTCI issues. Again, if we had more time, we could spend a lot of time discussing those. We are worried about some other things, and there's been some mention of them already today. We do know that the NCOIL members are looking very closely at insurance company restructuring mechanisms and how to be able to do that in a way that accomplishes good, but doesn't saddle the society with the risk of increased numbers of insolvencies. We're also somewhat concerned and have been historically with related party transactions within the insurance space. So as we move forward now on slide 20, what we're really hoping to do, as we have been doing for a long time, is to use the experience we've gained to work with legislators, with regulators, with industry, and with other stakeholders to make sure that we are prepared for whatever happens to come down the pike our way in the future. And we like to, you know, I was thinking before this started, I think this is the 5th time I've been asked to testify before NCOIL over the course of the last 3 decades or so. Historically, we've had a great relationship with NCOIL as we have with the regulators. And I think having that relationship and maintaining it into the future is going to be important to all of us as we seek to protect consumers against anything that might confront us in the coming years. So with that, Madam Chair, I'm going to say thank you, and also that I'd be happy to answer any questions that you may have now or later. My contact information is on slide 21, and I would welcome inquiries from you or any of your members.
Thank you so much. Anyone have any questions? No? Thank you. It was very informative. I appreciate it. With that, we will end our Thursday. So can I have a motion to adjourn? And a second? We are adjourned. Thank you.